My name is Dr. Karen Chung from McMaster University, and I thank you for this opportunity to present to you today. I have no conflicts of interest with respect to this presentation. I've received funding to conduct research on rehabilitation and outcomes in critically ill children. I've been given the distinct privilege of introducing to you today the concept of ICU liberation in pediatric practice. Liberation is a series of complementary evidence-based practices that work synergistically in a dose-dependent manner to reduce ICU-related morbidities. It is also known as the A2F bundle, referring to each of its practice components. These bundles may be referred to by other names. In our center, we refer to it as PICU Liberate, while our colleagues in Italy refer to their bundle as Liberazioni, or Liberaction. However you choose to refer to liberation bundles are a means of delivering ICU-based rehabilitation consistently to every patient every day. These bundles are designed to reduce harm and optimize functional outcomes and quality of life in critically ill adults and children. Why is rehabilitation important in critical care? First of all, most of our pediatric patients survive the critical illness. PICU mortality is currently at an all-time low. Improvements in survival have been accompanied by a change in our patient population. We have a growing population of PICU survivors with chronic complex diseases. These children now occupy the majority of our PICU beds and resources. They have the longest length of stay and the highest mortality. ICU-based rehabilitation is needed now more than ever because improved survival has been offset by an increased rate of ICU-acquired complications. Morbidities such as iatrogenic withdrawal, delirium, and ICU-acquired weakness are now unacceptably common in the PICU. These morbidities occur as a consequence of common, tradition-based practices that we've been applying with the best of intentions in our PICUs over the last 2 to 3 decades. These consequences have direct impact on patient outcomes while they're in the PICU. They result in increased mechanical ventilation duration, increased length of stay, increased mortality, and increased costs. Our interventions not only impact patient outcomes while they're in the PICU, we now have strong evidence that children who survive critical illness experience physical, cognitive, psychosocial, and family-based sequelae that persist long after they leave the PICU. ICU rehabilitation is therefore important in critically ill children not only to improve short-term, but also the longer-term sequelae that we now collectively refer to as the post-intensive care syndrome in pediatrics. Liberation is not a one-time intervention to be considered during the latter part of one's ICU stay. ICU liberation expands the course of critical illness. Remember that the definition of rehabilitation is to preserve function. Hence, we should think about ICU liberation bundles early during critical illness to preserve organ function as much as it is an intervention to preserve overall functioning and quality of life in critically ill patients. We now have strong evidence that ICU liberation practices improve patient outcomes. Applying the A2F bundle reduces the risk of delirium in both adults and children. In adults, liberation bundles reduce mechanical ventilation duration by an average of 3 days. ICU liberation also decreases the risk of mortality, ICU readmission, and even the need for rehabilitation post-ICU. There are benefits not only at a patient level, but at an institutional level. Liberation improves the process and quality of care without increasing workload or adverse events. It improves interprofessional collaboration and is cost-saving. ICU Liberation is therefore now recommended as a standard of care for critically ill adults and children. There are several clinical practice guidelines now in circulation, including the SCCM adult recommendations, which are now in its second iteration, and the recently published pediatric guidelines. Despite these recommendations, rehabilitation bundles are currently inconsistently applied in pediatric ICUs. This international study that we conducted across 161 PICUs in North America, Europe, and Brazil showed that only 9% of PICUs have incorporated the A2F components into routine practice. Only 26% of PICUs had early mobilization guidelines, and less than half reported routine delirium screening. The same is true in adult ICUs. This recently published international study reveals that less than half of the participating ICUs had written guidelines for rehabilitation bundles. Furthermore, having a guideline available does not mean that that guideline will be applied to the patient. The rate of actual application of each bundle component to the ICU patients in this study was very low. So I am impressed that this year the organizers of the SCCM Critical Care Congress have dedicated multiple sessions not only to the important topic of ICU liberation in children, but specifically on how to implement aspects of the bundle in the PICU. This is one of 3 sessions dedicated to this topic, and I'm excited for our next speakers to present to you on how to bring liberation into practice in the pediatric ICU. We need to talk more about how to implement. For ICU liberation to work, it needs to get to the patient. The ICU Liberation rehabilitation bundles were introduced more than a decade ago, but adoption of evidence into clinical practice takes time. However, the evidence suggests that it may take even longer to de-adopt unnecessary practices. This is important to consider, particularly as rehabilitation in the ICU requires de-adoption of practices that have been steeped in tradition. Furthermore, ICU liberation is complex. It consists of several bundles that require coordination from multiple interprofessional team members. The COVID-19 pandemic has highlighted that ICU liberation can be vulnerable. We have witnessed a regression in rehab practices during this pandemic. The resurgence in deep sedation and benzodiazepine use and restriction of family presence has highlighted again that these traditional practices directly result in adverse patient outcomes. I'd like to end by sharing with you 5 reasons why I love ICU liberation. First and foremost, it's fun. It's innovative, it's rewarding, it is inspiring to see our critically ill patients awaken and mobilize and communicate with us. Liberating children in the PICU motivates us to think outside of the box because you are dealing with kids. It's not just about ambulation, it's about getting down on the floor with our patients. Because of PICU-based rehab, I've come to learn of different pieces of equipment in the PICU that I didn't even know existed and are accessible to us through our rehabilitation therapists. I love it because this is a problem you cannot solve alone. PICU rehab is the one intervention that is highly dependent on team collaboration and communication. I have learned more about what each team member does and the value of each and every one of those members more than ever before through integrating these practices. In short, ICU liberation brings people together. Rehabilitation is what the families in PICU prioritize. Mobilization increases family engagement, and in turn, family engagement increases the odds of mobilization. I love PICU rehabilitation because it has allowed me to interact and truly engage families and make their agenda the focus of our research. PICU rehabilitation shines a light on other aspects of our care which we have till now pushed to the back of the PICU. These are all important aspects of the PICU environment that are important for our patients' recovery. These are what patients and families prioritize. I love Liberation because there are not just physical benefits, but psychological and emotional benefits. Here is how PICU rehabilitation makes some families feel in their own words. It made me aware that he is not dying. It seems like he's going to live. You knew there was some physical benefit to it, but for her, it was something to look forward to. Emotionally, we don't get much around here, so psychologically, it was so beneficial. It gave me hope. I challenge you to find another ICU intervention that makes patients and families feel this way, that motivates them and gives them hope. Last but not least, I love PICU Liberation because it has led to, in my opinion, unprecedented willingness to share resources and ideas and support for each other across the globe. That is the power of Liberation. If you share it, it will mature and improve and permeate into practice. Thank you for your kind attention, and I look forward to your questions.
Hello, and thank you for the opportunity to present and to also help kick off this special session related to the bundled care of the critically ill child, which represents a joint effort on the part of the SCCM Pediatric Sedation and Analgesia Guidelines Task Force and the ICU Liberation Group. My name is John Birkenbosch. I'm a pediatric intensivist at Norton Children's Hospital in Louisville, Kentucky. I have served as the co-chair for the Pediatric Sedation and Analgesia Task Force, and am a co-author of the recently published 2022 Society of Critical Care Medicine Clinical Practice Guidelines on Prevention and Management of Pain, Agitation, Neuromuscular Blockade, and Delirium in critically ill pediatric patients with consideration of the ICU environment and early mobility, or what we have come to call the Peds-PANDEM Guidelines. While you will hear many specifics of the guideline recommendations over the course of this session, my purpose for the next few minutes is to provide an overview of the processes underlying the development of these guidelines. I have no relevant financial disclosures or conflicts of interest. My objectives for this talk are to provide a brief historical perspective regarding the guideline development, a discussion of the methodology used in generating guideline recommendations, and then to take a walk through the structure and format of the guidelines, both to aid in navigating them, including a discussion of why the final version of the guidelines and associated supplemental content are structured as they are. I'll start with full disclosure and admit that these guidelines took a lot longer to develop than intended, and for that I apologize on behalf of myself and the task force. The process began with a request for volunteers in 2008 to join a new SCCM task force related to sedation and analgesia. The impetus behind developing this task force was twofold. First and foremost, there was a desire to develop a pediatric-specific guideline that would mirror what the Adult Pain, Agitation, and Delirium, or PAD, task force was in the process of doing, which was to revise the first adult PAD guidelines that had been published in 2002. However, this group was going to do so using a much more formal and rigorous evidence evaluation process, the grade methodology. In tasking this revision, the Society recognized that a similar effort needed to be undertaken for pediatric ICU patients, given their unique needs and the substantial differences that exist between pediatric and adult ICU sedation practices. There was also an understanding by the Society that, while other pediatric guidelines were in existence, they were either older, relatively limited in scope, or had not been developed using as rigorous an evidence review process as was going to be done by the adult PAD group. And this reaffirmed to pediatric leadership within the Society that the time had come to develop a more rigorous and comprehensive pediatric guideline. If I recall correctly, I was one of 2 prospective volunteers to attend the meeting, and ultimately left agreeing to co-chair the effort. Shortly thereafter, we started to work on building the task force of individuals with an interest and expertise in pediatric sedation. As our intent was for the developed guidelines to be applicable to all members of the critical care team, we also sought to be a multidisciplinary group and include representatives at minimum from the physician, nursing, and pharmacy disciplines. One of our biggest stumbling blocks was the absence of a methodologist to help us navigate the grade process, as no pediatric trained methodologists existed within the society at the time. Initially, we were advised to a degree by our adult-based colleagues, but eventually they told us they were unable to provide full assistance given their lack of expertise in pediatrics. Eventually then, one of the members of our task force agreed to undergo some advanced formal grade training and was able to fill this methodologist role. After all was said and done, the final team consisted of 20 pediatric critical care physicians, several of whom were also practicing anesthesiologists, 6 pediatric nurse practitioners, and 3 clinical pharmacists. While all of the nurse practitioners had bedside nursing experience, in retrospect, I wish that we had thought to include members with active bedside nursing experience as well. As the team was being assembled, we also started developing the plan for the final product and formulated the questions that we wanted the guidelines to address, irrespective of whether or not we felt that there would be adequate evidence with which to answer them. While we had initially planned to limit our scope to the same as the adult PAD task force, sticking to sedation, analgesia, and delirium, this expanded over time. The questions that we developed were divided into 2 categories: descriptive ones that would set much of the perspective for the actionable questions, which would be formally graded and from which recommendations would ultimately arise. As one can imagine, with a roster that changed substantially over the years, perspectives regarding the direction and format that the guidelines should take evolved, including addition of new questions and an expansion of the topics to be discussed. Ultimately, we felt that we wanted to create a single document, broader in scope to what the adult PAD group had done, and so topics including neuromuscular blockade, various non-pharmacologic therapies, tolerance, and withdrawal were added. In 2019, our initial draft, all 194 pages of it, was submitted to the Society for their review. Perhaps not entirely surprisingly, it was sent back to us with a request for major revision, including substantial reduction in its length. After significant brainstorming about how we were going to address all of the requests, the task force agreed on a plan to restructure the guidelines to correspond as much as possible with ICU Liberation themes, the A through F bundle. As our proposal was going to contain many of the ICU Liberation bundle elements anyway, this made intuitive sense. In October of 2020, we submitted a revision to SCCM, and it was divided into the following 7 domains of pediatric critical care practice: pain, sedation and agitation, iatrogenic withdrawal, neuromuscular blockade, delirium, pediatric environment, including family and sleep hygiene, and early mobility. To make a long story short, this revision was much more palatable to society leadership, and with some additional revision based on society and Pediatric Critical Care Medicine editorial staff review, the current guidelines were accepted for publication in November of 2021. It's worth taking some time to understand the evidence evaluation process that our group utilized. As best we could, evidence was evaluated using the grade methodology. Details of this methodology have been extensively published, so I won't belabor them here. Suffice it to say that this methodology had us evaluate evidence using a fairly rigid process and a very structured process. Our initial literature search was performed in conjunction with a certified medical librarian. Despite reservations about relying on older data, due to concerns that we might not find an adequate volume of data with which to evaluate some questions, our initial search went back as far as 1990. Although when feasible, only more recent literature was relied upon for recommendations. Following the request for revision of our initial submission, a second search was performed by a different librarian and identified literature through early 2020. As appropriate, task force members were also encouraged to submit additional studies to the dataset based on their own datasets or personal knowledge. For evidence evaluation, each question was assigned a primary and a secondary reviewer. The primary reviewer performed an initial screen of potentially relevant literature, drafted tables detailing relevant studies, along with an evaluation of their strengths, weaknesses, outcomes, and overall quality. The secondary reviewer verified the accuracy of these primary evaluations with methodologist assistance when deemed necessary. Reviewer pairs then drafted recommendations with a summary rationale and the evidence table that was brought to the responsible subgroup for evaluation, critique, and revision as needed. They then went to the full task force for a similar review. Final amended recommendations were voted on by the entire task force, with adoption of a recommendation requiring participation of greater than 70% of the task force in voting and a greater than 80% approval by those who voted. For recommendations in which task force members had a potential conflict of interest, that member abstained from voting. 3 levels of recommendation were incorporated into the final guidelines. Practice proposals were deemed to be either strong or recommended, or conditional, meaning suggested, based on the quality of evidence. Strong proposals represent practices for which high-quality evidence was found and for which further evidence was deemed unlikely to either change the recommendation or the task force confidence estimate regarding it. Conditional proposals represented practices where evidence was less robust and for which it was deemed likely that new evidence could alter either the recommendation or the group's confidence in it. While not formally part of the grade process, we finally also included an option for a good practice statement. These represented practices for which only very low quality of evidence was found, but which were either, based on consensus discussion, felt to be likely beneficial and associated with little or no risk. In the final publication, we were able to present 44 recommendations, 14 strong and 30 conditional, in addition to 5 good practice statements. In no way did this cover all of the questions we initially asked, the unanswered ones being omitted due to a lack of sufficient evidence from which to make a formal recommendation. As many specific recommendations will be highlighted in subsequent talks, I'll limit the remainder of this discussion to some of the themes that we felt crossed over domains or were present in multiple domains. First off, we stress that comfort provision in the pediatric ICU requires a process. The first step in this process is to know where your patient is at, which is why in multiple domains we stress the importance of frequent assessments using validated scoring tools. Following this assessment, subsequent treatment should be geared to a predefined target or goal, which may mean addition or removal of a therapy, or that the patient was in the place that they were desired to be. Finally, as there are potential undesired consequences to any intervention in critical care, provider teams are encouraged to anticipate the possible development of these consequences and, insofar as possible, mitigate the modifiable risks for their development, rather than just focus on their management once developed. The guidelines themselves are now published as two separate but complementary documents. What you will likely be most familiar with are the main guidelines, which are published in the electronic pages of PCCM. This document contains all actionable recommendations with an accompanying brief rationale summarizing the literature upon which that recommendation is based, and the document is divided into each of the 7 domains of practice previously discussed. Table 1, which is found early in the document, also lists these recommendations with no accompanying discussion for quick reference. Tables 2 and 3 list questions for which we were unable to make recommendations due to lack of evidence and which represent areas where further study would be desirable. And lastly, Figure 1, for which I cannot claim credit, provides an elegant representation of the interplay between the assessment, management, and consequence themes discussed in the preceding slide. The supplemental digital content complements and expands on the main guidelines and can be accessed using the link embedded multiple times in the main guidelines themselves. This content contains discussions of all of the descriptive questions we posed, as well as additional background information that informed the actionable questions, including a more detailed discussion of the many assessment tools referenced in the main guidelines, for example. This content also includes 23 tables, many of which provide substantial expansion regarding the literature used in developing specific recommendations. For readers wanting this deeper dive, or for whom the rationale provided in the main guidelines seems too superficial, I highly encourage accessing this content. It is our hope that these guidelines provide a useful tool for you. They are meant to be a living document. With intentional revisions occurring every 5 to 7 years, we hope that they become increasingly robust as new literature either better informs current recommendations or allows for the creation of recommendations that this iteration was unable to provide. And lastly, I would be remiss if I did not thank the many members of this task force, especially my co-chair Heidi Smith, without whose tireless efforts and support these guidelines would not have come into existence. As a task force, we also owe a huge thanks to the support staff at the Society for Critical Care Medicine, and in particular, I'd like to thank Ed Conway, who has been our liaison with the Board of Regents and a source of immense support throughout this process. And lastly, I'd like to thank the reviewers from SCCM Council, the Board of Regents, and Dr. Tasker at PCCM, whose input ultimately helped us produce a final guideline product that we as a task force are proud of. With that, I will conclude and thank you for your attention. I encourage you to post your questions or comments using the chat function, and we will take time later in the session to address them. Please enjoy the rest of the session.
Good morning. In the next 10 minutes, I will present the findings and recommendations of our task force related to assessment of pain and sedation and the utility of protocolized sedation or daily sedation interruption in mechanically ventilated children. I have no financial disclosures to report. We are all familiar with the many benefits derived from effective analgesia. Accurate assessment of pain is critical, but significant barriers exist which can be patient-related, such as developmental variation or premorbid neurocognitive delay, illness-related neurobehavioral sequelae, or factors related to the caregiver, such as lack of training or time to perform assessments. The PICU question was, what pain assessment tools should be used in critically ill patients? Pain assessment tools can be divided into self-report and observational rating scales. Self-report is gold standard in children who can express themselves. Although validated in children as young as 3 years of age, it is most reliable in children 6 and older. Observational scales incorporate behavioral variables with or without physiological variables. No pain or sedation tools have been validated in children receiving neuromuscular blockade. Therefore, changes in vital signs may indicate acute pain and should be addressed. This table shows the most commonly used self-report scales, including the VAS, NRS, Oucher, and Wong-Baker Faces Pain Scale. Although there is considerable experience and validity in a wide range of pediatric populations, none have been formally validated in critically ill children or in the ICU setting. There are no data to suggest that any one scale is superior to the others. The NRS tends to be used in older children as it requires a user to be capable of translating their pain into a number. Both the Oucher and FACES pain scales are convenient and used in a broad age group, requiring the user to associate their pain to a series of pictures depicting a continuum of severity of pain. The Oucher uses actual photographs while the FACES scale uses drawings as illustrated in this slide. In children unable to provide self-report, observational scoring systems that incorporate a combination of behavioral and physiological variables are utilized. 4 pain scales have been validated for use in critically ill children. These scales are caregiver-based assessment tools. The FLAC, Comfort, and Comfort B are the most widely used. The FLAC score evaluates 5 behavioral components. However, its validity for assessment of non-surgical or non-procedural pain in critically ill children has not been evaluated. The revised or RFLAC was developed and validated for use in nonverbal and cognitively impaired children. The Comfort score was initially developed and validated to assess general distress in critically ill children. Subsequently, it has been shown to also be valid for differentiating pain from other sources of distress. The Comfort B scale removed vital signs due to concerns regarding their reliability for the assessment of pain. There are some disadvantages to the use of both the Comfort and Comfort B scales. Both scales are not intended to evaluate pain during intermittent painful procedures and consequently are not useful in assessing procedural pain. The Comfort scale is also thought to be time-consuming given its 8 variables. Similarly, the Comfort B scale requires a 2-minute assessment. Shorter observation periods have been shown to increase the risk of underscoring the patient's pain. Our recommendations include: we suggest that in critically ill pediatric patients 6 years of age and older who are capable of communicating, that pain assessment via self-report be routinely performed. We recommend the use of either the FLAC or Comfort B scales for assessing pain in children who cannot communicate. We also recommend the use of observational tools rather than vital signs alone for assessment of postoperative pain, and we suggest the use of observational tools rather than vital signs alone for assessment of procedural-related pain. Our PICO question regarding assessment of sedation was: what sedation assessment scales are valid for assessing depth of sedation in critically ill patients? This table shows the 4 scales which have been validated in mechanically ventilated children. The Comfort B and the State Behavioral Scale have been validated in several PICU settings. The SBS has been shown to reliably differentiate adequate from over or under sedation in patients not receiving neuromuscular blockade. It follows 8 behavioral dimensions. Physiologic vital signs were excluded as they have been shown to have low sensitivity and specificity for quantifying the degree of sedation or agitation. The Comfort scale measures 8 clinical parameters, including 2 physiologic parameters, heart rate and blood pressure. The Comfort B scale eliminates these 2 physiologic parameters, identifying scores of less than or equal to 11 as over sedation and greater than or equal to 22 as under sedation. A limitation of this scale, however, is that scores between 11 and 22 do not adequately predict under or over sedation. Thus, the Comfort B scale is commonly used in conjunction with other observational scales, such as the Nurse Interpretation of Sedation Score, or NISS. Although the Richmond Agitation and Sedation Scale has only been validated in a single trial, it is extensively utilized in pediatric critical care as it forms the basis for determining the appropriateness of delirium screening with the PCAM ICU and CAP-B delirium scoring tools. Although no studies exist comparing these 3 scales with each other, the quality of evidence supported a strong recommendation for the use of the Comfort B or SBS scales versus a conditional recommendation for the RAS. The PICO questions related to protocolized sedation included: Should critically ill pediatric patients requiring mechanical ventilation routinely be assigned a targeted depth of sedation? Is protocolized sedation superior to non-protocolized sedation? Should routine daily sedation interruption or DSI be implemented in children receiving continuous sedative infusions? And are there interventions that are associated with or reduce the risk of unintended device removal? 10 studies were found evaluating the impact of protocolized sedation and analgesia on various outcomes. In the only RCT, Carell and colleagues compared outcomes between PICUs randomized to provide protocolized care versus units providing non-protocolized care. Protocolized care included, but was not limited to, a targeted sedation score, prescribed drugs, sedation weaning, and extubation readiness. There were no between-group differences in inadequate analgesia or sedation, duration of mechanical ventilation, PICU length of stay, opioid or benzodiazepine exposure, or the development of an iatrogenic withdrawal syndrome. However, the percentage of study days in which patients were awake and calm while intubated was higher in the intervention group. Several before and after studies reported improvements in one or more of these outcomes, particularly benzodiazepine exposure. No studies reported worse outcomes with protocolization. We do not suggest the addition of DSI to sedation protocolization due to lack of improvement in outcomes. Vet and Associates conducted a randomized trial of protocolized sedation plus DSI versus protocolized sedation alone. DSI was not associated with improvements in outcome. In the Carell study I previously mentioned, DSI was included in the protocolized group when sedation was deeper than a predefined score. Only 4% of patients required DSI for oversedation. Therefore, DSI may not be necessary when goal-directed sedation is utilized. 6 quality improvement studies found rates of unintended device removal consistently decreased after implementation of bundled components, which I will show you in a minute. In addition to recommendations regarding DSI, our task force suggests that all pediatric patients are assigned a targeted depth of sedation using a validated sedation assessment tool at least once daily, and we suggest the use of protocolized sedation in all patients requiring sedation or analgesia during mechanical ventilation. During the peri-extubation period, when sedation is typically lightened, we suggest the following bundled strategies to reduce the risk of inadvertent device removal. Assign a target depth of sedation at increasing frequency. Consider a sedation weaning protocol. Consider unit standards for securement of endotracheal tubes and safety plan, and restrict nursing workload to facilitate frequent patient monitoring and to decrease sedation requirements and the risk of self-harm. In summary, a self-report pain assessment tool is the gold standard. However, it is most reliable in kids 6 years of age and older. We recommend either the FLAC or COMFORT-B in non-communicative patients. Our task force recommends using the COMFORT-B, SBS, or RAS to assess sedation. We suggest assigning a targeted depth of sedation and using protocolized sedation. We do not recommend the addition of DSI, and during the peri-extubation period, we suggest the use of a bundled strategy to decrease the risk of inadvertent device removal. I would like to thank the Society of Critical Care Medicine for the opportunity to present our task force findings.
Hi, I'm Christina Betters, and I'm a pediatric intensivist at Vanderbilt University in Nashville, Tennessee. Today, I'm going to talk about a framework for success when you're implementing the A element of the ICU Liberation bundle, taking into consideration the PANDEM guidelines as well. I have no disclosures or conflicts of interest. Here is the basic framework for success that we're going to discuss today. So it's a 6-pronged approach that can be used for implementing any bundle element. I'm not going to discuss specific choices of analgesia or sedation, as that will be covered in a lecture later on in this session. After implementing several ICU Liberation bundle elements and learning from negative and positive experiences, I present to you a general framework for success. We're going to work through this today as it pertains to the A element, but again, many of these ideas could be used for any of the ICU Liberation elements. Before you get started with a new protocol, you want to assess your current environment. What is the current practice in your unit? Are patients assessed for pain? If so, what tools are being used? Are they the validated pediatric tools that PANDEM recommends? How often are your patients being assessed for pain? What happens if their pain score is too high? Where is all this being documented? Are there official hospital policies and standards? How are people trained on such processes? Knowing all this will be important before you set out to implement a new practice. In addition, I recommend searching the literature and reaching out to pediatric critical care colleagues for advice. When I was starting a new sedation protocol, mentors and colleagues across the world were very helpful for me when I emailed out asking for their practices and what went well and what didn't. Here I've included a couple of journal articles about pain assessment practices in the PICU. The first one, Lors et al., reviews implementing a new pain assessment protocol and how they train their nursing staff. I think is very helpful to review their article if you are starting fresh with pain assessments. The second one, it was helpful for me to realize that there is a lot of different practice going on internationally for pain assessments in the pediatric intensive care world. Next, you want to build your team of key stakeholders. This is very important when you're implementing any of the ICU Liberation bundle elements. So for the A element, as you can imagine, nursing leadership, medical leadership, nursing educators, and bedside champions as well as pharmacy involvement was extremely important. We also had help from our child life specialist and occupational therapist for rolling out a non-pharmacologic sensory pyramid to treat pain and anxiety in our unit. As you work with your key stakeholders to formulate a plan, there are some big questions that you want to ask that pertain to the A element. What tools are you going to use to assess your patients for pain? You can also talk about sedation assessment tools as well. Dr. Basunder talked about the validated pediatric pain and sedation assessment tools that the PANDEM guidelines recommend in his last talk. How often should you be assessing your patient? Here at Vanderbilt, we assess our patients every 2 hours for pain and sooner if their pain scores are higher or if they're getting a painful procedure. Your sedation scores may also depend on if your patient is receiving sedation, how often you're assessing them. Where are you going to document your pain and sedation assessments? Do you have a flow sheet and an EMR that you just need to revise? Do you need to build something new from scratch? And then once you create a protocol, how are you going to train people on it? And do you require institutional approval for your protocol? I also want to highlight here that a couple years ago we made an ICU Liberation implementation toolkit. You can access this on the ICU Liberation website and have it emailed to you. I put the link here. It's pretty simple. You just ask them to send you the toolkit and put in your email information. This was meant for adult and pediatric ICU. And it was to help you with implementing the ICU Liberation bundle, but also advocating to administration about the importance of resources for implementing the ICU Liberation bundle. I'm going to take a moment here to talk about leveraging the EMR. So I know many people here use Epic or Cerner or another type of EMR. When you are doing pain assessments, it's a really nice way to have a clean area to document that everybody can see. So here on the left-hand side, this is our Epic-based flow sheets where our nurses document pain assessments. They actually can choose in the rows to wrench in a specific pain tool that they're using, like the FLAC featured here below. And then they can report the score and the location and the type and even the goal, and then can document what intervention was taken for the pain. Here on the right, I wanted to show you the start of our sedation protocol. So we created this flow diagram, but then I'm going to show you how we built this into Epic because it was quite complicated. And it was quite complicated because we were following hospital accreditation and Joint Commission standards. So here we took that really complicated sedation protocol and we built it into an Epic order set for our providers. This is really important here, especially because we're a training institution, and so we have residents that come in and out of our ICU on a monthly basis. And so although our fellows and NPs and attendings may know our sedation protocol really well, we do have quite a bit of turnover in our unit for frontline providers, and we wanted to make it as easy as possible when ordering the sedation protocol. So you can see here there's a lot of text, but all the nursing administration instructions and everything that's following Joint Commission standards is built into this order set. And there's even an area where they can upgrade to second-line sedation or third-line sedation if their patient needs more sedatives. Change is hard, and so before you go live with your tool or implementation, you want to educate. I think it's really helpful to rely on your group of key stakeholders to ask them what the best methods of education are. And then we like to use multimodal education. So not just a single way, because we know that everybody learns in a different manner. So of course, you can send out email notifications. You can assign online modules. For our sedation protocol for the providers, I actually made a video and posted it into a private YouTube channel for people to see how to order the sedation protocol. You could do patient simulations. You could present at staff meetings. For us, we also do something called shift updates, where we come in the beginning of morning or night shift and give updates to the staff. And then in-person, in-the-moment training is also extremely helpful. So you can round on the unit whenever you go live with your new protocol. And then it's always helpful to have quick references or education that's embedded in the EMR if you have an EMR. That way, when people are in the moment taking care of patients, if they have a question or need, there's something quick for them to reference if they can't get a hold of you. And then it's time to implement. And of course, there's going to be education with your implementation, but we also like to start with education before we go live. Similar to any QI project, I would consider a small trial run or test of change. So if you were able to have a simulated EMR environment with fake patients where you can trial your protocol and documentation and order set, that can be really helpful to find any issues before you push it out to the real live environment. I would recommend being patient. Of course, change is always hard, and being present. So for instance, when we went live with our new sedation protocol, I would walk around bedside to bedside and talk to the nurses and ask them how things were going and get their feedback. I think that's important for you to know things that aren't going well, but also important for them to know that you care and you recognize that there may be tweaks that you have to make. How do you sustain change? First and foremost, celebrate wins. Give positive feedback to your staff. Let them know that their work with the new protocol is directly impacting patient care, and share a clinical story for them. Audit regularly to see what adherence is to your protocol. On the ICU Liberation website, you can download the minimum data set, or the MDS, which is an Excel file where you can input data to see what your compliance is with the A through F bundle on your patients. Soon, EMR-based flow sheets will be coming out for Epic and Cerner that are pediatric specific to also assess compliance with the A through F bundle in our patients. We hope those will make it much easier for sites to check their compliance. And then as far as onboarding processes and competencies, ensuring that your education is embedded in these processes will help it to be sustained over time. I put our sensory pyramid here to remind myself of the intense culture change we had over several years in our unit. This pyramid was built by our occupational therapists and child life specialists as a non-pharmacologic means for treatment of pain and anxiety. Culture change takes time, sometimes on the order of years. So I wanted to show our timeline to show you that patience pays off. In summer 2018, we formed a committee to create a new sedation protocol. Unfortunately, it took us almost an entire year to create our protocol, get hospital approval, and build everything into our EMR. So we didn't go live with that new sedation protocol until summer of 2019. And then that fall, after we had implemented the new sedation protocol, we implemented a sedation weaning protocol, which is also part of the new PANDEM guidelines. And then in spring 2020, we implemented our sensory pyramid. So we're constantly moving forward, and we try and be patient and know that culture change takes time. Thank you so much for your attention, and I will be staying for the Q&A session, but also feel free to email me any questions you may have.
My name is Samer Abu Sultani. I'm from Riley Hospital for Children at Indiana University Hospital. Today I will talk about the B element, which is how to implement both spontaneous awakening and breathing trials in PICU. In my slides, I will mention some elements of the Pediatric Ventilator Liberation Guidelines, which is supported by an R13 grant from the NIH and also funds from Indiana University Department of Pediatrics. I think all of us agree that the B element is the keystone for ICU liberation. Patients on mechanical ventilation need more sedation and pain medications. They are at risk for delirium. Usually they are immobile, and there is decreased interaction between patients on mechanical ventilation and their families. This is also supported by the SCCM, who included the ventilator liberation as one of the 5 elements of the Choosing Wisely campaign. Pediatric critical care providers try to balance between 2 important outcomes when we are talking about pediatric ventilator liberation. The length of mechanical ventilation, which is associated with increased sedation, immobility, delirium, ventilator-associated events, ventilator-induced lung injury, and cost. And the other element is the risk for extubation failure. And this is associated with its own morbidities, like increased duration of mechanical ventilation, increased PICU length of stay, ventilator-associated events, cost, and possibly mortality. So the big question you have now, how you can do pediatric ventilator liberation? If you look at the data from PICU, worldwide the adoption of the B element of the ICU liberation is not great. It's about 50%. It goes down to below 30% in Canada and as high as 60% in Brazil and Europe. So you ask why the adoption of this B element is so low. Part of it may be because of lack of guidelines for pediatric ventilator liberation. So we conducted this project to establish a guidelines. We recruited a diverse panel of 26 international multi-professional experts in pediatric ventilator liberation to assess the literature and come with recommendations regarding different elements of the extubation readiness testing. I'm excited to announce that we are done with the systematic reviews related to the guidelines, and we should be publishing the guidelines sometime in the summer. So stay tuned. What I'd like to focus now on is the SPT or ERT safety screening. What criteria to use, when to do it, how often, who should do it, RN, RT, physician, and how to do EMR integration to augment the compliance with the safety screening. So the first question that comes in mind, what criteria do you use for safety screening? If we look at the phases of mechanical ventilation, we can see that there is the escalation phase where you are trying to stabilize the patient, you're increasing ventilator support. Then there is this plateau phase where the patient is stabilized, you might have slight increase or decrease in the ventilator setting, and then there is this de-escalation phase where you start to decrease the ventilator support gradually. So the question, when to do this SPT-RT safety screening, the threshold in the literature varies. There is people that they are more aggressive and they choose high ventilator settings. There is people they are in the middle, and there is people that are really very conservative. They want the patient to be in very low settings before they consider doing an ERT or SPT. In the literature, most of the ERT or SPT safety screening is done by bedside RT and RN, and there is a collaboration between different team members to do the safety screening. Usually it's done every 12 to 24 hours, usually at the beginning or at the end of the shift. People consider no scheduled OR trips in the next 12 to 24 hours to do the safety screening. For the respiratory parameters, most literature use no significant escalation of ventilator support in the last 12 or 24 hours. PEEP threshold usually 6 to 8. Some people are more aggressive and they use a PEEP of 10. FiO2 threshold usually below 0.4 to 0.5 to keep saturation within goal for both cyanotic and acyanotic patients. For peak inspiratory pressure, most literature use 22 to 25. Some aggressive studies use a higher PEP like 30. More conservative studies use a PEP in the teens to do the screening. For the hemodynamic parameters, most studies use no escalation of vasoactive support in the last 12 hours. Usually, you will be a low-dose vasoactive medications, blood pressure and heart rate within normal range for age. The optimal way to implement an SPT or ERT in your unit is to have a multi-professional ERT work group where you have your physicians, respiratory therapists, nurses, informational technologists, and pharmacists work together in developing an ERT bundle. This ERT work group look at compliance and outcomes of ventilator liberation and look at barriers and promoters in implementing the ERT bundle in the unit. This is an example from our center on how to implement an ERT bundle. There's two graphs in this slide. Graph A show the compliance with screening. As you can see, our compliance was above our goal of 80, and the screening correctly was also above 80. This slide shows the control chart for extubation failure rate and median duration of mechanical ventilation on the right side. The extubation failure rate center line dropped from 7.8 to 4.5% without change in the median duration of mechanical ventilation during the study. Similar approach was adopted by Lohberger and his colleagues. And what did they find? That the time between patient meeting screening criteria dropped from 33 hours to 3 hours after implementing an RT-driven pathway for extubation readiness assessment. Other centers were not as successful. As you can see in the left graph, the gray line, the protocol compliance was high at the beginning of the study, but it started to degrade, especially during busy winter months. And as you can see here, their compliance was just 56%. This low compliance may be affected their outcomes. As you can see, the duration of mechanical ventilation didn't change. The initiation of SPT to extubation didn't change. The hospital length of stay and PICU length of stay didn't change also. Now let's switch gears to talk about spontaneous awakening trials, or SAT. The spontaneous awakening trials are not commonly adopted in many PICUs. The PANDEM guidelines recommendation is not to add daily spontaneous awakening trials to sedation protocolization due to lack of improvement in outcomes. Most of the centers' practices mirror the bundled intervention published by Sandwich recently. It includes assessment of sedation level using a validated sedation tool every 4 to 6 hours, daily screening for readiness to undertake an SPT, initiation of SPT when screening criteria were satisfied, and daily multi-professional round to review the sedation goals and sedation plan and SPT results. Of the 18 centers participated in the study, 5 didn't use a sedation scoring tool, 14 didn't have a sedation protocol, and 15 didn't have a ventilator weaning protocol. After study implementation, you can see that 82% of the centers start using comfort for assessment of sedation. 85% had a target set comfort goal. The readiness for SPT assessment was not as great at 74%, and even the SPT initiation was as low as 40%. The median difference of length of mechanical ventilation was 6 hours less in the intervention arm. This may be reflecting the compliance with the sedation assessment and sedation goal, and not SPT screening and SPT initiation, as the SPT initiation was lower. The PANDEM guidelines suggested using a bundle during the peri-extubation period when sedation is typically lightened. This is to prevent unplanned extubation. This bundle includes 4 elements. The first one is to assign target depth of sedation at increasing frequency to adapt to change in patient clinical status and communicate strategies to reach that goal. Consider a sedation weaning protocol. Consider unit standards for ET tube securement, and restrict nurse workload to facilitate frequent patient monitoring. So, how to incorporate this in the SPT ERT safety screening? Let's start with the sedation assessment. The sedation should be lightened so patient can be spontaneously breathing. You need to assess cough and gag and have a target for your sedation assessment. Patient shouldn't have abnormal intracranial pressure, shouldn't have active seizures, and for sure shouldn't be on paralytic. To implement an RT in your unit, you need to look how to empower multi-professional team members to perform the ERT. This will be your bedside RN, bedside RT. You need to perform audits to look at the compliance, to look at your outcomes, extubation failure, length of mechanical ventilation, use of NIV or high flow post-extubation. You need to give people feedback and do re-education when needed. EMR is a powerful tool that you can use when implementing an ERT in your unit. It can help trigger to initiate ERT when the safety criteria is met. It can improve communication, especially between shifts, between nurses, RTs, and physicians. It can be used to initiate and have a QI reports that you can use to improve on. And lastly, you can collect your data from EMR to refine your ERT as needed. Lastly, to improve our understanding about ERT and what we need to do to improve this worldwide, the best way is to establish a Pediatric Ventilator Liberation QI collaborative, where each center will form their own multi-professional team. They will implement ERT bundle, look at barriers and promoters, and then come to the main collaborative, discuss these promoters and barriers, and try to improve the implementation phase of ERT. If you have any questions, please email me or send me a message via Twitter. Thank you very much for your attention.
Hello, my name is Pete Johnson. I'm a professor of pharmacy at the University of Oklahoma College of Pharmacy, and I also practice in peds critical care, primarily in the cardiac ICU now at Oklahoma Children's Hospital at OU Health. It's my honor to present how to choose the right analgesia sedation in the pediatric patient. As far as disclosures and conflicts, I have no financial obligations related to the purpose of this presentation. We'll make some references to off-label use of medications. And I guess lastly, a disclosure is I was a member of the Peds-PANDEM guideline task force, so I'll be talking about aspects related to that. So my objective as it relates to the line of presentations for this content is to identify barriers to optimizing agent selection, facilitators for implementation, education and care, and create a protocol to standardize and monitor success of our patients. So first up, we'll look at barriers to optimizing agent selection. As I was thinking through this, I identified 4 potential barriers that many of us might encounter on a daily basis in our critically ill children. The first barrier would be drug shortages, which for some of us might be like a 4-letter word. It's been a problem in the US for many years, although I feel like over the last 10 to 15 years, it's become even more problematic. There's a lot of different etiologies that are out there, some problems in quality manufacturing process that can lead companies to halt production, natural disasters. I know many of us were familiar with some shortages, particularly with fentanyl and opioids as a result of Hurricane Maria in Puerto Rico in 2017 that halted drug manufacturing. And of course, last but not least, is the pandemic. Certainly this resulted into just raw material production issues. People weren't able to be in factories to manufacture products, as well as the difficulties in just sick patients, primarily, at least initially with adults, requiring so many therapies, opioid sedatives, that it just led to a decrease in distribution to other hospitals. I found it interesting that there was a recent survey of approximately 1,400 adult and pediatric health systems in the United States. They looked at drug shortages and answered a number of different questions related to this. In terms of the most common shortages that they noted, it was particularly with albuterol, MDIs, sedative anesthetics, and neuromuscular blockers, which obviously led to a number of clinical issues. So one of them is just confusion among healthcare professionals, not knowing what exactly we have in stock. I can tell you from the pharmacy side of things, sometimes there's confusions between our operations distribution staff and the clinical staff knowing exactly what we have in play, and that can further lead to just miscommunication with the medical team. It could require conversion of analgesic sedatives and neuromuscular blockade, and then those factors could lead to an increase in medication errors and adverse events. Another barrier that I sort of thought of is maybe just the patient himself. What about those that have renal or hepatic dysfunction? Obviously, it could require consideration of alternative agents. The Peds-PANDEM guidelines do have some tables that might help you, just as a reminder. So it's supplemental digital content tables 3, 10, and 14 for sedatives, analgesics, and neuromuscular blockade. Just in terms of some general recommendations, one consideration would be those without active metabolites might be better than those with renal dysfunction, as well as those that have hepatic dysfunction, maybe avoiding those that are metabolized through other enzyme pathways other than CYP450, as displayed here. Another barrier that I sort of thought of is tolerance. So tolerance could impact the choice of selected agents, generally defined as a decrease in the pharmacodynamic effect that requires an increase in dose for that desired or decreased effect. So there could be a number of etiologies just with a drug, the PK or PD, so pharmacokinetic or dynamic, so receptor desensitization, upregulation of mechanistic pathways, pharmacokinetic medicinal structure, so many are familiar with fentanyl is a semi-synthetic short-acting opioid and is known to have higher degrees of tolerance than morphine or hydromorphone. There could be patient-specific factors as well. The cumulative duration increases the risk of tolerance. Some studies have said those that are admitted for medical as opposed to surgical diagnoses may be at higher risk, as well as those with frequent ICU admissions. The problem with all this is that clinical studies often define tolerance as a doubling of a dose. I know a number of studies have looked at fentanyl in particular, or a doubling of their initial dose and bolus dose. The problem is that definition is a little bit too simplistic and doesn't take into account some of those pharmacokinetic and dynamic issues. As a result, the Peds-PANDEM guidelines, we do not specifically address this because honestly, there needs to be a more robust definition that defines exactly what tolerance is for our patients. Another barrier would be obesity. It's estimated between 19 to 22% of children in health systems and PICUs are obese. I know in the state of Oklahoma, this might even underestimate some of our admissions. Obesity can lead to a number of pharmacokinetic alterations, in particular can affect our sedatives and analgesics and even neuromuscular blockers. It can increase adipose tissue as a result of a decrease in lean body mass, which can in particular affect the volume distribution, the loading dose that obese kids need, as well as their maintenance dose as well. It also can increase their total body clearance, which could affect the renal clearance of some of these medications. So dosing adjustments have definitely been evaluated in critically ill adults, such as adjusted body weight, ideal body weight, lean body mass, and different references have cited different factors might be needed to be used in certain medications versus others. But really, there's a lack of universal definitions, in particular with lean body mass in children. My colleagues and I actually evaluated the top 20 infusions that critically ill obese children received in the PICU and the cardiac ICU. So we found almost half of them were a sedative and analgesic or a neuromuscular blockade agent. We also did a literature search, so we only found 3 of these agents that there were PK studies that really have evaluated the impact of pharmacokinetics with obesity, but a number of them have not been studied. So there are a number of unanswered questions. The Peds-PANDEM notes these questions with neuromuscular blockers. In particular, we don't comment on the lack of data or the need of data for sedative and analgesics, but it definitely is there. And so there really is a paucity of studies in impacting the right dose, maybe the right agent to use in some of these children. So now that we talked some of the barriers, I don't know if I had answers for all the barriers, but just highlighting what some of them are for agent selection, etc. Let's look at considerations for protocol creation. So what's the state of need for this? Well, as noted in the PANDEM guidelines, we referenced this particular study. So this was a survey in which they set out to assess sedation, sleep promotion, and delirium practices among PEDS critical care providers. It was a survey of World Federation of Pediatric Intensive and Critical Care Society members over approximately a 6-month period. In terms of results, they had 341 respondents, the majority from North America, but there was representation from all across the world. 70% of the respondents notarized that they used patient-specific sedation goals. However, only about 42% of them actually implemented that in terms of their daily rounds or patient care goals themselves. So even though they were having these goals, maybe not necessarily doing much with them, I hate to say. Also, they looked at some other things that I think are important to note, whether institutions had a unit-wide or written protocol for all mechanically ventilated children. So as you can see, there are significant differences between North America and other countries across the world, as well as who is the driver of that sedation protocol. As you can see in the United States at that time, the majority of respondents noted nurses were, versus other countries, primarily physicians as well. So basically a lot of heterogeneity in this topic. So what are some considerations of protocols? So some that when I was thinking about this topic, I approached it by each sort of category of agents. So analgesia and sedation, obviously we recommend scoring tools for pain and sedation. So that should be a part of this protocol consideration. Selection of agents, no specific recommendation for first-line opioid. We do recommend dexmedetomidine for first line, and then give considerations for second line and adjunct agents as well. So that could be helpful in designing your protocol if you haven't already done so. In terms of neuromuscular blockade, we do provide recommendations for depth of blockade, selection of agents, which basically we don't recommend one over the other, as well as other supportive care considerations like routine passive eyelid closure with eye lubrication. In terms of additional consideration, if you work in a facility that has a PICU and a cardiac ICU, you might need unit-specific protocols. You might need to make room for adjustments that for patients that don't really fit the norm. Maybe those that have a high degree of tolerance or multiple admissions or other genetic anomalies that make selection and dosing of these agents a little bit different than the normal PICU or cardiac ICU population. What about continuous infusions versus intermittent infusions? In the PANDEM guidelines, we don't necessarily recommend one over the other, although I will say if you can get away with doing intermittent dosing of agents, that's of course always best. And then another layer of complexity is PRN analgesics and sedatives. So the Joint Commission has implemented what is called medication management standards on medication orders and administration. And they require specifically an objective indication of PRN agents. So for example, for opioids, a pain score of 4 to 6. They require sequence administration. So if they're getting acetaminophen plus morphine, providers must illustrate or elucidate what they want to give first. And then also in nursing instructions as well. So this can make it a little bit complicated in terms of creation of your own protocol. So let's look at one possible way around this, or one way to address this. So there was a group from Johns Hopkins that set out to address this issue. They conducted a quality improvement project in which they studied pre versus post design of the protocol that was compliant in terms of the PRN sedative, analgesic, and neuromuscular blocker orders for those issues like we identified on the previous slide. So their method was they first conducted a failure effects mode on PRN orders on those 3 requirements that we discussed. So the indication, the timing, and the nursing instructions for analgesic, sedatives, and paralytics, and then also some additional supportive care consideration for analgesics. They created an example of SMART list that they created with medications and the potential PRN indications, as you can see depicted on this slide, that was designated for their electronic medical record. So they implemented education on the Joint Commission requirements themselves, as well as implemented the protocol. So the way that they did this is the first period that they assessed was before they did education, before they implemented this order set. Period 2 was after they implemented the education, but it was before 17 weeks before the protocol implementation. And period 3 was that 13-week period after order set and education was initiated. So what they found was that there was significant increase in order compliance with PRN medications for the Joint Commission requirements from their first period, so before any education, to after they implemented some education. And then after they implemented the education and the protocol, compliance was somewhere around 90%, and it stayed that way through the end of the study. So I think this illustrates having a protocol, educating your team on why this is important and why we have to do this. Definitely help them achieve that 90% goal. So I think just conclusions that they had is development of an order set, increased compliance, that you need to develop a unit-specific protocol and then implement educational strategies. Well, let's look at considerations for implementation and then education and care specifically. We talked about barriers to agents, but there are also barriers to protocol implementation. Just with the culture of an institution itself, training on specific standard assessment tools, maybe a transfer may be needed from providers to nurses, depending on what your protocol looks like. A greater emphasis on using analogous sedation, so less sedation, and maybe using the backbone of opioids, maybe a different practice than some are familiar with. And then definitely the introduction of early mobility could throw a kink in how people approach this. There also could be a lack of agreement on providers on how they want the protocol to look, what they wanted to do, etc. And then familiarity of the protocol design as well. In terms of education and implementation, I definitely would recommend selecting a physician champion and interprofessional leadership, so from nursing, but I'd also argue involve your clinical pharmacist, just with all the implications as we've already talked about, from Joint Commission requirements to dosing to other considerations as well. Identify some sort of plan for education. So education is nice, but how are you going to do it? Are you going to have online modules, face-to-face didactic sessions, Zoom in this day and age? Identify those key champions, so from bedside nurses to sort of your key people that might be then enabled to in turn educate others. And those are people are necessary to ensure sustainability of a protocol. One example that I thought was interesting that I just pointed out is the sandwich trial, which many may be familiar with. It was a multi-center step-wedge cluster RCT in 17 cities in the United Kingdom. And they assessed sedation and veneration liberation protocol in approximately 9,000 children. And just what I wanted to highlight here is their education plan. So if you haven't implemented a protocol, maybe you're thinking through the best way to do it, they did just what I presented on the previous slide. They had an online course that included 7 different modules. People had to make a certain score. They had some champions, but they also implemented face-to-face training, knowing that that online module may or may not have been a full or good way to engage our adult learners. So what about protocol sustainability? Some of you may have implemented a protocol, but is it sustainable? So this particular study is published a number of years ago. They compared a duration of sedatives and other outcomes immediately after they implemented a protocol over a several year time frame back in the 2008 to 2009 versus 5 years later after the protocol had still been used. They wanted to assess, is it still working? So some of the education and implementation considerations. So in early 2008, when they implemented the protocol, the staff received detailed training, in-person training, but following implementation, new staff just received education via that online module, not as the face-to-face in-depth engagement that was done initially. And no changes were done in the protocol during the study. So what they found was the Cox proportional hazard model found, controlling for severity of illness and diagnosis, that more patients in the 5-year period following were more likely to be sedated and had a longer PICU ICU stay. So kind of showing that maybe that protocol initially did some good things, but after it had been out for a number of years, didn't necessarily have as dramatic of results as they initially found. The one positive is that they did note a reduction in benzodiazepine exposure that remained throughout the different study periods. So what about some additional sustainability considerations? Identify ongoing educational strategies. So I would argue from that previous study, having a face-to-face communication is really necessary versus just an online module. Development of some sort of data collection and ongoing audit and assessment to identifying how sustainable are the outcomes. Maybe initially had great outcomes, but you find out through that audit that things are not going as well and need to re-strategize how to sustain a protocol success. Need to also obtain ongoing feedback with sedation practices. Maybe as your unit gets bigger, you have more of some types of subsets of critically ill patients, you might need to tailor your protocol to meet their needs. And then I would argue, again, a continued need for interprofessional leadership with nursing, pharmacy, respiratory, physical therapy, etc. In conclusion, there are definitely several barriers that we discussed in terms of just analgesias, sedatives, and neuromuscular blockers themselves. There are numerous factors involved with protocol creation, as well as some barriers to implementing that protocol and its sustainability in the future. Thank you for attending this presentation. I hope you at least give you some things to think about for creating or evaluating the sustainability of your own protocol.
Good afternoon. My name is Dr. Heidi Smith. I will be presenting on the Assessment, Prevention, and Management of Delirium recommendations from the 2022 SCCM Peds-PANDEM Clinical Guidelines. I would like to disclose that I currently am receiving NIH funding for a pediatric sedation trial through NHLBI. The prevalence of delirium has become more accurately quantifiable with the validation and implementation of pediatric-specific delirium tools. The PANDEM guidelines consolidated data from 15 large prospective cohort studies, with reported prevalence of ICU delirium ranging from 5 to 66%. More remote studies often reported on hyperactive delirium, which is the least common subtype of ICU delirium among pediatric patients. Reports of prevalence have increased with more recent validation studies of delirium tools that identify all motoric subtypes, including the most common hypoactive form. This form can be easily missed when patients are not routinely undergoing delirium monitoring. It is pertinent for the clinician to be aware of key risk factors that have been associated with ICU delirium in pediatric patients and encourage routine monitoring. Key predisposing or pre-existing factors include younger age, shown to have a significant association with delirium in 8 prospective cohort studies. Furthermore, presence of baseline neurodevelopmental delay was associated with a triple risk of delirium during critical illness compared to patients with normal development. Poor baseline nutritional status and cyanotic heart disease have also been associated with development of delirium. Precipitating factors, which include those that are related to the critical illness itself, but also iatrogenic or treatment-related factors, may be modifiable. Factors such as sedation that includes a dose-response component to benzodiazepine exposure and risk of ICU delirium. Also immobilization, additional to need for mechanical ventilation and length of cardiopulmonary bypass. 9 prospective cohort studies consistently demonstrate that children with delirium have increased PICU and hospital length of stay. 5 prospective cohort studies demonstrated strong associations between delirium and prolonged duration of mechanical ventilation. Median costs were reported to be 85% higher in children who ever suffered from delirium in a large prospective cohort study of 484 patients. The association between delirium and mortality is not clear. In a high-quality prospective longitudinal study of around 1,500 patients, a strong and independent association between delirium and mortality was observed. However, in another large retrospective study of around 2,500 patients, there was no such association. Despite this uncertainty, the vigilance to both monitor and management is key, as there remain additional large knowledge gaps regarding delirium and potential long-term complications of cognitive impairment, attention deficits, and post-traumatic stress symptoms. We answered 2 specific delirium assessment questions. Which delirium screening tools have the best validity and reliability in critically ill pediatric patients, and should critically ill pediatric patients undergo routine delirium screening? Delirium is a state of acute brain dysfunction, a disturbance of both consciousness and cognition, develops acutely with often a fluctuating course of altered mental status, a cardinal feature of inattention, sometimes disturbances in cognition, all triggered by a medical or surgical condition. A series of 6 pediatric-specific tools were reviewed based on validation literature. The task force focused on 3 main tools that were validated in a blinded fashion with use of a reference standard consisting of experts in the field of child and adolescent psychiatry employing DSM-4 or 5 criteria for delirium diagnosis. Additionally, strength of evidence for validation studies included appropriate cohort size, blinding, and easily reproducible methods. The Carell assessment for pediatric delirium and the pediatric and preschool confusion assessment methods for the ICU were validated under robust methods and large cohorts to improve generalizability. The CAPD was adapted from the Pediatric Anesthesia Emergence Delirium Scale, or PAED. The CAPD added 3 additional hypoactive elements, including communication of needs, underactivity while awake, and prolonged response to interaction to meet the deficit of the PAED. The CAPD performed with a sensitivity of 94% and specificity of 79% compared with reference standard in a cohort of 111 patients. The tool is an observational, using interaction over a nursing shift to grade these 8 domains using a Likert scale. The pediatric and preschool confusion assessment methods for the ICU are both interactive and observational point-in-time assessments for delirium adapted from the highly valid precursor, the adult CAM-ICU. These tools require the presence of DSM criteria for delirium, including acute change or fluctuation from baseline mental status and inattention. The PCAM-ICU for patients 5 years and older was validated in a cohort of 68 patients and performed with a sensitivity of 83% and specificity of 99% against a reference standard. The preschool CAM-ICU was further adapted for use in infants and children developmentally less than 5 years of age and validated in a cohort of 300 patients aged 6 months to 5 years, having a sensitivity of 75% and specificity of 91% compared to the reference standard. We recommend use of the PS or PCAM-ICU or the CAPD as the most valid and reliable delirium monitoring tools in critically ill pediatric patients. We further recommend routine screening for ICU delirium using one of these validated tools upon admission through ICU discharge or transfer. We answered 3 specific questions on prevention and management. Among critically ill pediatric patients, what non-pharmacologic or pharmacologic sedation strategies reduce the incidence and/or decrease the duration or severity of delirium in critically ill pediatric patients? And does the use of haloperidol or atypical antipsychotics reduce the occurrence rate and/or decrease the duration or severity of delirium in critically ill pediatric patients? Though the impact of the ICU environment is considerable, there remains a dearth of information regarding the impact of environmental modifications such as artificial light, minimization of noise, and bundling care on development or duration of delirium. As pediatricians, however, we can reflect on the importance of nutrition, sleep, and physical activity for healthy children, and therefore the ongoing push to assess these adages in the ICU setting are important. Family presence, despite our historical inclusion of family in the care for pediatric patients, there remains a lack of data regarding impact of family presence on delirium. Prevention strategies focused on vigilance of assessment and resolution of disease-related causes and iatrogenic sources that may exacerbate delirium is of great importance and can be quickly reviewed using the acronym BRAIN MAPS, ranging from adequate oxygenation, remove or reduction of deliriogenic drugs, the ICU atmosphere or environment, immobilization, new organ dysfunction, metabolic disturbances, and the three really hard ones, having patients more awake with less pain and exposure to less sedation. Less sedation seems like a simple request, but it's hard to follow through, as being awake may not fit the needs of every critically ill pediatric patient. So we will discuss how we walk this line to both support patient needs and decrease risk of delirium. Peds-PANDEM recommendations for non-pharmacologic strategies for delirium. Given low patient risk and possible patient benefit to reduce the incidence and/or decrease duration or severity of delirium, we suggest the following non-pharmacologic strategies: optimization of sleep hygiene, use of interdisciplinary rounds, family engagement on rounds, and family involvement with direct patient care. We further suggest performing early mobility, when feasible, to reduce the development of delirium. The pharmacologic management of delirium in some ways is relatively straightforward. There is no drug that cures delirium. It becomes complicated because the primary goal is treatment of underlying causes, as we reflect on the acronym of BRAIN MAPS. The secondary goals become patient safety and mitigation of severe manifestations. In many ways, the pathway to decrease sedation exposure in relation to its impact on delirium is through our response to agitation. The word itself seems harmless, except when you are in the pediatric ICU. This word is not only a symptom, but creates what seems like a never-ending dilemma, but to which the answers to three simple questions may be helpful in decreasing iatrogenic harm in relation to delirium. Agitation is a symptom. It may be due to pain, anxiety, fear, iatrogenic withdrawal, or delirium. This symptom, however, often drives the use of sedatives and opioids in the PICU. The dilemma is whether agitation needs treatment, if there is adequate patient ventilator synchrony, and the patient is safe, hemodynamically or otherwise. The answer of three questions, which get back to the crux of the PANDEM guidelines, are: where is my patient now? Assessment. Where are they going? Reassessment. And how do I get them there? Make a plan. Meaning that maintaining a view of the overall path of the patient may allow the integration of other ways to address agitation than sedation alone, thereby impacting the development and duration of delirium. We incorporate what do we know with what do we do. Three larger prospective cohort studies have demonstrated that greater exposure to benzodiazepines is an independent risk factor for delirium. This does not mean that all patients who receive benzodiazepine will develop delirium, nor that other sedatives are not associated with delirium. We know that pediatric patients' needs are different, and only with a shift in the way we interpret agitation while providing adequate analgesia will we be able to impact avoidance or decrease of sedative exposure. We will need to be creative as a community to use non-pharmacologic approaches to support patient comfort. While we would all love for a new sedative to provide sedation without risk of adverse outcomes, we know without a change in our culture or expectation of sedation in the PICU that it will not matter what sedative we employ, the risk for delirium will remain. There may be a role for haloperidol or atypical antipsychotics in the treatment of severe manifestations of delirium, resulting from an imbalance in excitatory and inhibitory neurotransmission. Excessive dopaminergic activity leads to hyperactive manifestations such as combativeness or severe agitation, or excessive GABA or cholinergic activation leads to hypoactive manifestations such as lability and mood, withdrawing from caregivers, or a child not acting like themselves. Haloperidol is often used in instances of severe hyperactive delirium as it works through dopaminergic blockade. The associated sedation and relief of severe agitation can decrease use of other sedatives that may further exacerbate these manifestations of delirium. Atypical antipsychotics can be used for both hyperactive and hypoactive delirium with their broader effects on dopaminergic, alpha-2, and serotonergic receptors. The task force reviewed 10 retrospective cohort studies and 7 case reports or series, including around 350 pediatric patients receiving haloperidol or atypical antipsychotics for delirium manifestations. Generally, there was significant improvement in manifestations of delirium, with few reports of significant adverse drug events. However, we are cautioned by the lack of prospective cohort studies or randomized control trials. Additionally, any use of haloperidol or atypical antipsychotics is off-label for pediatric delirium. When used, goal is short-term use with reassessment and monitoring of pertinent side effects. We recommend minimizing benzodiazepine-based sedation when feasible in critically ill pediatric patients to decrease incidence and/or duration or severity of delirium. We suggest strategies to minimize overall sedation exposure whenever feasible to reduce coma and the incidence and/or severity of delirium in critically ill children. We do not suggest routine use of haloperidol or atypical antipsychotics for the prevention of or decrease in duration of delirium. We do suggest, however, that in critically ill pediatric patients with refractory delirium, haloperidol or atypical antipsychotics are considered for the management of these severe delirium manifestations. When used, we recommend a baseline electrocardiogram followed by routine electrolyte and QTc interval monitoring for patients receiving haloperidol or atypical antipsychotics.
Good afternoon. My name is Shari Simone, and I'm the Advanced Practice Provider Manager for Pediatric Critical Care at the University of Maryland Medical Center and a professor in the Doctor of Nursing Practice program at the University of Maryland School of Nursing. I would like to thank the Congress Planning Committee for the opportunity to present how to implement delirium screening in the PICU and what to do with your results. I have no conflicts of interest, but we did receive an interprofessional collaboration education grant for interdisciplinary student and trainee delirium education with our initial QI project. So my objectives are to highlight our PICU delirium QI efforts at the University of Maryland Medical Center, and then to discuss key delirium screening implementation strategies to promote successful implementation and sustainability. So our delirium assessment, prevention, and management QI project began in 2013. We were not screening for delirium, and recognition was based on clinical suspicion and a psychiatry evaluation. So our initial aim was to examine the impact of interprofessional collaboration to improve detection, prevention, and management that included not only PICU team members, but also pharmacy and psychiatry. So we assembled a task force in the fall of 2013 that included pediatric psychiatry, pharmacy, PICU intensivists, and myself. Our goals were to utilize interdisciplinary expertise to improve staff and trainee delirium education and then to develop a delirium protocol to implement universal screening, enhance early and systematic detection, develop prevention strategies, and standardize delirium treatment. So we developed an evidence-based delirium clinical protocol based on the limited evidence at that time. This protocol included universal pain, sedation screening, along with delirium screening using a validated tool. We chose the Cornell Assessment of Pediatric Delirium, or the CAPD tool, based on its ease of use, especially in mechanically ventilated children. This is a condensed picture of our 4-page algorithm, which includes assessment prevention measures, and with positive delirium screen, an acronym for identifying potential etiologies, and non-pharmacologic and pharmacologic treatment and monitoring parameters when antipsychotic treatment is prescribed. So our intervention was to implement an evidence-based delirium protocol for assessment, prevention, and treatment. And our data measurements included screening compliance, delirium prevalence, a demographic and clinical data of delirium cases, and then staff trainee pre-post knowledge, attitudes, and skills survey. So one important interdisciplinary education forum was the creation of a Brain Rounds monthly conference. This was a well-attended conference by the PICU multidisciplinary staff, which include intensivists, advanced practice providers, fellows, residents, nurses, and pharmacy and psychiatry and students. The conference was led by me with psychiatry, pharmacy, and PICU participation. We presented in-depth review of delirium cases, especially complex cases, and then we would review screening, prevention, diagnosis, and management strategies, and modify our treatment and algorithm as needed. We also created this booklet, Pediatric Team, which stood for Training, Education, Assessment, and Management of Delirium, and included information on delirium criteria, subtypes, on the pathophysiology, risk factors, screening tool, and our algorithm. So although our original QI project was to implement delirium screening, you can see here that our time frame extended from 2013 to 2015. And this was mainly due to performing multiple QI PDSA cycles with evolving adult evidence of bundle strategies to not only decrease delirium, but also liberate critically ill patients from mechanical ventilation in the ICU. So at the top, in December 2013, we rolled out comprehensive education to the multidisciplinary staff, and then began delirium screening and initiation of the delirium protocol, and then conducted daily monitoring of the screening adherence. We also did a pre-assessment survey of delirium knowledge and attitudes of the staff. And then in February 2014, we initiated the Brain Rounds monthly conference, and also around that time received an interprofessional educational seed grant for student and trainee delirium education. And over the next year, created multiple educational activities. And this grant was really instrumental in driving intensive and structured education, as well as maintaining interdisciplinary commitment. In March 2014, the CAPD tool had been revised and re-educated the staff and continued daily monitoring of screening adherence. And again, as there was increase in evidence of bundle strategies in adults to decrease delirium, we phased in these bundle strategies by adding core teams to create the bundles and then to roll out education and implementation. We screened 1,875 patients over 22 months with a phased-in implementation of the 3 protocols, the delirium, sedation, early mobilization protocols, and we standardized delirium assessment using the CAPD tool and implemented prevention and treatment strategies. We also created multiple resources to provide comprehensive education to the multidisciplinary staff and interdisciplinary students. And as you can see here, our delirium prevalence decreased from 28% to approximately 12% over this time frame, which was a remarkable success for our team. And then we published this work in Pediatric Critical Care Medicine in 2017. There are several key implementation strategies that influenced the success of our Delirium QI project that I hope are helpful to those of you beginning this process or struggling with implementation. First, creating an interdisciplinary QI team with the right individuals is critical, in addition to having multidisciplinary PICU team members. Psychiatry and pharmacy expertise was critical to influence key PICU stakeholders and drive change, especially as delirium research was limited in critically ill children at the time of our implementation. And having a shared commitment with project lead and interdisciplinary champions. I was the project lead, but was fortunate to have a psychiatrist, clinical pharmacist, intensivists, APPs, and nurse champions that were highly engaged. They assisted with education on nights and weekends, with discussions in multidisciplinary rounds, huddles, and early consults. This also assisted with achieving buy-in from PICU leadership, which is necessary to support process change and culture change. And our monthly Brain Rounds conference helped, especially as it had consistent interdisciplinary representation and assisted with consensus on the process, management, and outcomes. You must choose a validated pediatric delirium screening tool. There are 3 recommended in the new PANDEM guidelines. The first is the Pediatric Confusion Assessment Method for the ICU, also known as the PCAM ICU, which assesses children 5 years of age and older, and the preschool version, which assesses children under 5 years of age. This is a point-in-time assessment with interactive and observational components. The third tool is the Cornell Assessment of Pediatric Delirium, also known as the CAPD tool. This is an observational assessment that is performed over several hours of the shift and is validated in children 0 to 18 years of age. Another key implementation strategy is identifying and addressing barriers to screening. Understanding the ICU context is really critical and requires a deep dive assessment of your unit culture, resources, leadership commitment, competing projects that are going on, unit priorities, and readiness to change. We obviously implemented our project well before COVID, and we're not faced with some of the challenges that we are seeing now, including staffing shortages. Also, assessing the staff knowledge and attitudes and beliefs pre-implementation can be really helpful in understanding barriers to expect. And then typically pilot implementation involves paper documentation, but limiting redundancies in documentation is important and can greatly affect adherence. We did screen using paper tools for the entire 22 months, so it's not impossible, but we enlisted unit secretaries to distribute and collect tools at night, and they had a very clear responsibility and ownership of this. And having frontline ownership with nurses, APPs, physicians, the clinical pharmacist, and the unit secretary also greatly assisted with overcoming barriers and creating solutions. And Costa and colleagues in 2017 performed a systematic review and identified 107 barriers to the A to F bundle implementation. And really many of these are the same as I've described, but they identified 4 themes: patient-related, such as safety concerns, hemodynamic instability, clinical-related, such as staff lack of knowledge or workload, protocol-related, not having a protocol, and ICU context. So using a multifaceted or multimodal approach to train clinicians in delirium screening is really important. Startup education must be comprehensive and rolled out to all multidisciplinary staff through the use of in-services, train-the-trainer sessions with frontline staff. We also created nursing competency training with case-based scenarios and performed co-assessments to evaluate for accuracy of screening assessments, especially with hypoactive and mixed delirium cases. We also added education to the nursing orientation and our monthly resident education. We created web-based resources and other educational materials such as our booklet. You can also develop pocket cards. We had posters, PowerPoint presentations readily available. And our algorithm is easily accessible on our PICU internet page. And then, of course, just-in-time education by delirium staff champions must be ongoing. So what data should be collected and what should you do with your results? Assessing staff knowledge pre and post implementation provides great insight on barriers and facilitators for implementation and also sustainability, and was very helpful to us. The primary process outcome is screening adherence. You can see in this graph in the upper right-hand corner that ours was high throughout, and this was because of unit nursing and the unit secretary champions ensuring screening, and also that the paper forms were readily available. Clinical outcomes should include the delirium prevalence, your patient demographic and clinical characteristics of delirium cases. And the success of your data collection is going to be dependent upon who's collecting the data, what databases are available, and what can be extracted from the electronic medical record. If you have limited resources, I would consider using some creative resources such as the interdisciplinary students. When we first started, we had psychiatry and pharmacy students that assisted with this data collection. That was extremely helpful. And then disseminating the data and using the impact of the implementation to sustain practice, the practice change is key. We presented our screening compliance and prevalence throughout our project in our monthly case conference and in our PICU quality review meetings, which was really helpful for momentum and also commitment to the project. It's also important to monitor throughout so you can quickly address, such as a dip in compliance, and retrain and reassess new barriers. Your results can then be used to demonstrate the need to standardize practice. Delirium screening must be incorporated into the nursing workflow, and ideally embed all delirium documentation into the electronic medical record. This is really a key strategy for sustainability. We discussed screens and multidisciplinary rounds, and here you can see our ICU checklist, which includes the delirium assessment. And then also we have incorporated the delirium assessment into the nursing flow sheet. So you want to make it all easy to do and not easy to forget. Continuing to improve, monitor, and disseminate results are critical for sustainability. Use a QI method for implementation, such as the plan, do, study, act cycles, which are easy to do and should be incremental and continuous. Having at least one team member with QI expertise is also really helpful. Our initial aim, again, was not to create multiple bundle strategies, but our successful implementation of delirium screening really created momentum and led to further improvements. Having a stepwise approach was really successful for us. Doing too much at once can be overwhelming for busy clinicians. And also celebrating successes and disseminating internally frequently is really important. We presented at multiple pediatric nursing APP grand rounds. This really helped to spread the effort. And since we have assisted pediatric inpatient units and our NICU with delirium screening and management. So screening is the first major step in delirium prevention and treatment, but the other bundle strategies were also necessary for preventing delirium. This was our statistical process control chart, which demonstrates the impact of the 3 ICU bundle process changes that we implemented over the course of 22 months. Initially, as you can see, our delirium prevalence increased with screening, as it should have, but over the course of the bundle implementation, there was a nice stepwise decrease in prevalence, which we were extremely excited about. So what do we continue to do with our results? We have since implemented 5 of the 6 ICU Liberation A to F bundle strategies. We have incorporated strategies to improve family engagement and empowerment. Our PICU Connect program here in the middle includes the use of Zoom during multidisciplinary rounds and therapies when parents are unable to be at the patient's bedside. These pictures are pre-COVID, but you can see the mothers zoomed in for rounds. And laying the groundwork with delirium screening has really facilitated further QI efforts to improve our practices related to these A-to-F bundle strategies. We have also modified our delirium pharmacologic management and shared our work. So I hope sharing our delirium QI project and strategies we found to be key for successful implementation and sustainability are helpful for those who are planning to implement delirium screening. Thank you, and I look forward to questions.
Hello, and thank you again for the opportunity to present and continue this discussion about how the Peds-PANDEM and ICU Liberation efforts can complement and inform each other. If you missed my earlier session, my name is John Birkenbosch. I am a pediatric intensivist at Norton Children's Hospital in Louisville, Kentucky. I served as the co-chair for the Sedation and Analgesia Task Force, and I'm a co-author of the 2022 Peds-PANDEM Guidelines. I will be discussing some of the key recommendations made in the guidelines relating to choice of analgesic, sedative, and neuromuscular blocking agents. While this presentation will focus primarily on pharmacologic choices, it should be remembered that there are several non-pharmacologic interventions for the provision of comfort to the critically ill child as well, and these are discussed in the guidelines and supplemental content. I have no relevant financial disclosures or conflicts of interest. My objectives for this part of the session are twofold. First, I would like to remind you of the importance of providing appropriate analgesia and sedation in the PICU. and follow that with a discussion highlighting specific recommendations related to the choice of analgesic, sedative, or neuromuscular blocking agent. It probably comes as no surprise that pain and agitation are commonplace in the critically ill child, regardless of their reason for admission to the PICU and the invasiveness of the therapies they are receiving. Similarly, it should come as no surprise that pain and/or agitation have multiple sources in the PICU patient. I think we're all aware of the obvious causes of pain, such as surgical site pain, traumatic injury, or agitation such as the presence and need to protect invasive devices, or distress due to just being in the ICU. However, multiple other causes exist that may be underappreciated. We may forget that the underlying inflammatory response associated with critical disease may not just make patients feel unwell, but may be overtly painful. Similarly, pain is described by older patients in the PICU regarding the presence of an endotracheal tube, especially during suctioning. Perhaps even less well appreciated are the pain associated with immobility or reduced mobility experienced by a large number of our patients, or the distress, which is probably cumulative in nature, that the sleep disruption so prevalent in our PICUs can also create. I would advocate then that this list serves as a reminder to implement the suggestions made earlier in this panel about the frequent need for assessments of pain and distress in all of our patients. Coincidental with the high prevalence of pain and agitation in the PICU is a need to understand the adverse consequences of inadequately addressing them. In the acute phase, we, quite rightly, focus on patient safety, including the need to prevent inadvertent device removal and facilitate cooperation with therapies. Just as important, we must remind ourselves of other possibly longer-term adverse consequences to PICU interventions, including the development of withdrawal syndromes, delirium, and post-intensive care syndrome. While these developments are almost certainly multifactorial in origin, our pharmacologic choices likely play a role. Regarding analgesia, I would like to highlight two recommendations that we make for analgesic choices in the PICU. This probably seems like the most obvious question to ask, but was still one that we felt we should address. What class of analgesic is superior for treating pain in the critically ill pediatric patient? Not surprisingly, our recommendation, and it is a strong one, is that IV opiates be used as the primary analgesic for treating moderate to severe pain. This recommendation is based almost exclusively on multiple survey-type studies, all of which reported that IV opiates were, by far, the most commonly used agent for treating most pain in the PICU patient. Additionally, opiates remain the agent of choice for treating moderate to severe pain in the World Health Organization pain ladder. Consequently, despite the lack of comparative studies, we feel comfortable making this recommendation, particularly since no other viable analgesic options exist for longer-term analgesia provision to the ICU patient. One thing our group would have liked to see was evidence comparing efficacy and/or safety between opiate agents. Unfortunately, we were unable to find any head-to-head comparisons between opiates in PICU patients, leaving the question of which opiate provides a therapeutic and/or safety advantage as an unanswered question. While pharmacologic principles suggest that synthetic opiates may be preferred in the setting of renal dysfunction, the evidence here was, again, insufficient to allow us to make a recommendation. A similar insufficient body of evidence existed for questions relating to the utility of shorter-acting agents, such as remifentanil, to facilitate early extubation. A potentially more interesting question is that of the utility of adding non-opiate adjunct medications to opiate-based analgesic regimens, specifically acetaminophen or a nonsteroidal agent. We are recommending the addition of IV or oral nonsteroidals to improve early postoperative analgesia, and we are suggesting their use to decrease opiate exposure in the immediate postoperative period. In the case of acetaminophen, we are suggesting their addition for the same two outcomes. I should stress that these recommendations apply to early postoperative outcomes and that we are not advocating for longer-term use of either agent. The evidence evaluating these recommendations derived from 2 systematic reviews and 4 randomized controlled trials, although I will just summarize the findings of the systematic reviews here. In the 45 discrete studies included in both reviews, addition of a nonsteroidal was addressed in 34. While not all studies addressed the outcomes we were interested in, the majority demonstrated improved pain scores and reduced opiate requirements with nonsteroidal addition. 42 studies addressed the addition of acetaminophen, and while the trend in results was similar to that seen with nonsteroidal agents, the proportional improvements were smaller, leading to conditional recommendations only. While there are several more recommendations related to sedative choice, due to time constraints, this section will be limited to highlighting 3. Similar to with analgesics, the first question we felt we needed to ask was if there was evidence to support a preferred sedative choice for the critically ill child requiring mechanical ventilation. While multiple agents are available to the critical care practitioner, survey-based studies have reported that benzodiazepines have long been the sedative class of choice in the PICU. Despite that, and based on available evidence, we are suggesting that alpha-2 agonists be used as the primary sedative class. We found 5 randomized controlled trials comparing sedative efficacy between alpha agonists and benzodiazepines, all reporting no difference between the 2 classes. However, 4 smaller RCTs comparing opiate requirements during sedation with these 2 classes all reported less opiate exposure in alpha agonist versus benzodiazepine sedated patients across multiple PICU populations. While greater mean reductions in heart rate and blood pressure have been reported with alpha agonist use, the need to intervene for overt bradycardia and/or hypotension has not been reported to be increased compared to benzodiazepine sedation. These data, combined with the growing evidence of an association between benzodiazepine exposure and delirium development, further informed this recommendation. Related to the above, we specifically evaluated the question of benzodiazepine versus alpha agonist sedation in postoperative cardiac surgical patients, as this population was thought to perhaps be more sensitive to the sympatholytic effects of alpha agonists. However, the evidence suggested that this was not the case, and we recommend alpha agonist over benzodiazepine-based sedation for postoperative cardiac surgical patients in whom early extubation is planned, and we suggest the use of dexmedetomidine sedation to reduce the risk of postoperative tachydysrhythmias. These recommendations were supported by data from 2 systematic reviews and 2 additional RCTs. Regarding early extubation, 1 systematic review and 1 RCT reported earlier extubation with dexmedetomidine use, with the other RCT finding no difference. This question was not addressed by the 2nd systematic review. Both systematic reviews, however, concluded that the incidence of postoperative tachydysrhythmias was lower with alpha agonist versus benzodiazepine sedation. As this remains an ongoing topic of debate within our discipline, the task force felt we needed to address the question of propofol use and associated risks. Despite its highly attractive pharmacologic properties, concerns regarding the development of propofol-related infusion syndrome, or PRIS, remain real. For that reason, our group spent probably more time evaluating the evidence here than for any other question. In the end, we are suggesting that propofol infusions be limited to a combination of less than 4 milligrams per kilogram per hour and for less than 48 hours to reduce the risk of PRIS development. Unfortunately, the available data informing propofol dosing recommendations is limited. While the initial developments of PRIS are almost 30 years old now, data addressing the role of propofol dose and/or duration and PRIS development remain limited. The suggestion to limit propofol dose and duration were based on data from 5 prospective observational case series. In all of these series, propofol dosing was limited to either less than 4 milligrams per kilogram per hour and/or a 48-hour duration in the vast majority of participants, and no cases of PRIS were reported in patients in whom propofol use was below these dose and duration limits. What remains unknown and has yet to be adequately studied is what the risks of PRIS development are when using propofol at higher doses and/or for longer durations. This is especially relevant as we have a greater understanding of the early signs of PRIS and how to more effectively screen for it than when the syndrome was initially described. Therefore, this remains very much a topic in need of further study. I'll conclude this session with a brief look at one recommendation regarding neuromuscular blockade use. While neuromuscular blocking agent use remains relatively common amongst the sickest of critically ill children, the data surrounding their use and impact on outcomes is sparse. Therefore, the only question we were able to find sufficient data from which to make a recommendation regarding neuromuscular blocker use was what are the necessary sedation and/or analgesia requirements during neuromuscular blocker use. While the evidence here is also limited, the best we could do is make a suggestion that analgesia and sedation should be adequate to prevent awareness during neuromuscular blockade. Before addressing the actual recommendation, I want to note that the task force asked many other questions regarding neuromuscular blocker use, including their benefits and impacts on outcomes, especially in the setting of severe respiratory disease, which is when neuromuscular blocking agents are most commonly utilized. Available evidence remains insufficient to address these questions. Within the PICU, there is also a paucity of literature evaluating the degree of sedation and/or analgesia required during neuromuscular blocker use, other than an intuitive feeling by most practitioners that awareness during neuromuscular blocker use would be unacceptable. The data supporting our recommendation comes primarily from the 5th audit of the Royal College of Anaesthetists of the UK and Ireland, which found that accidental awareness under anesthesia is as high as 1 in 135 procedures when children were directly questioned following their procedure. Methods to mitigate this result remain understudied. While the practice of neuromuscular blocker holidays during their use is gaining popularity, published data remain insufficient to address whether this practice truly reduces the incidence of unintended awareness. Similarly, while EEG-based monitoring, particularly with the BIS monitor, has demonstrated efficacy in terms of trending sedation depth in the PICU patient, data regarding their application during neuromuscular blocker use remain insufficient to make a formal recommendation. This therefore remains very much as well a topic for which further study is desperately needed. With that, I will conclude and thank you for your attention. I will again note that additional drug and non-pharmacologic interventions are addressed in the guidelines, but could not all be addressed here due to time constraints, and I refer you to the full guidelines and associated supplemental content for additional information. I also encourage you to post your questions or comments using the chat function and look forward to addressing them later in the session.
Hi, my name is Sapnika Chatgar. I'm the Vice Chair of Pediatric Anesthesiology and Critical Care Medicine at the Johns Hopkins University School of Medicine, and I'm thrilled to talk about early mobility and exercise. As I like to call it, illness doesn't mean stillness. Let's get started. If you're looking for one-stop shopping for all things PICU and NICU liberation literature, please go to bit.ly/Peds Liberation Literature, where I curate daily any content related to the ABCDEF bundle in pediatrics. We're here to talk about early mobility in critically ill children, and fortunately, we know what the landscape of mobility across the world is in pediatric intensive care units, including in the United States, the EU, and Canada. The prevalence of acute rehab for kids in the PICU study, or PARC-PICU, included 82 pediatric intensive care units or pediatric cardiac intensive care units across the United States and 1,800 patients. And what we found in US PARC-PICU was a wake-up call. On any given day in pediatric ICUs across the country, 1/5 of children were completely immobile and did not move from their bed. Additionally, girls and younger patients were less likely to receive PT or OT provided mobility, and patients with higher baseline function were at risk for a delayed PT or OT consult. And now, hot off the press, we finally have the 2022 SCCM clinical practice guidelines focused specifically on pediatric patients with regards to pain, agitation, neuromuscular blockade, delirium, and consideration of the environment and early mobility. However, we have a lot of work to do. In our analysis of 161 PICUs across 18 countries, early mobility initiatives were the least likely to be implemented in these ICUs of all of the ABCDEF bundle elements. So we essentially have created a culture of immobility. So the question is, why? Well, liberation is not a new concept. I love this quote from JAMA in 1899. It means a great deal to be put on their own feet in a short time rather than be confined to bed, having their weak backs and general debility increase rather than disappear after the operation which was to cure them. Dr. Emil Reus, JAMA, 1899. JAMA 1944. I love this title. The abuse of rest as a therapeutic measure in surgery. Prolonged bed rest is anatomically and physiologically unsound. Early restoration of medical and surgical patients to normal life is an essential feature of modern convalescent supervision. In 1998, Thomas Petty, one of the fathers of adult pulmonary medicine, said, "What I see these days are sedated patients lying without motion, appearing to be dead except for the monitors that tell me otherwise. By being awake and alert, they could interact with family, feel human, and sustain the zest for living, which is a requirement for survival." So where do we go from here? How do we negotiate making sure that we sustain the zest for living, which is a requirement for survival, with our culture of immobility in pediatric intensive care units? Well, we decided to tackle that back in fall of 2013 at Johns Hopkins. We realized that our culture of immobility was likely due to a variety of different factors, including oversedation, rapid escalation of drugs, PT and OT being an afterthought, not being called until all of the acute resuscitative measures had been addressed. Restraints were the rule and not the exception. We weren't talking about delirium at all. Benzos and Benadryl were being used to improve sleep, and family were simply observers in the process. And in this conceptual framework, I decided that immobility is really related to all of these different factors and that they have significant impact on patients and families, similar to post-intensive care syndrome in pediatrics. We know mobility has many benefits: blood sugar homeostasis, cardiovascular and pulmonary function, sleep-wake patterns, cognition, having a positive impact on the risk for depression. And we knew that we had some culture change goals that we needed to make. Every kid, every day. We couldn't put in place an initiative that was only intended for one specific patient population. We needed to get the experts to the bedside early. No child was ever too sick to turn away, or PT or an OT or an SLP. We wanted to focus on analgesia first, and then sedation only if needed. Kids and families can tell us what they need. And finally, sleep hygiene and delirium prevention mean more mobility. Contrary to popular belief, we did not receive any financial resources initially when we implemented PICU Up. It was completely the cost of multi-professional collaboration to promote culture change. All of these champions from each of these professions got in a room together and decided they wanted to make a difference. We came up with a cool name. That was the very first step, a name that everyone could rally behind and utilize as our shared mission. And we used the Translating Research into Practice model, or the TRIP model, for our quality improvement initiative. It's very important to note that I had never performed a QI project or led a QI project in my career. This was my first one, and this model made it very easy for me to learn the process along with my team to guide us all together. First, we needed to summarize the evidence, then identify local barriers to implementation, measure our performance, and finally ensure that all patients receive the interventions. We performed a very simple literature review because there wasn't much out there, and we found that EM at the time was safe and feasible in all of these studies in a very heterogeneous patient population, but it gave us the green light to move forward. So when PICU Up was born, it was a structured and interdisciplinary program. We wanted it to be integrated into the routine care of every critically ill child in our unit. Obviously, we wanted our outcomes to improve, from a standardized mechanism to increase activity level to lowering rates of mobility-associated complications, decreasing length of mechanical ventilation, and decreasing length of stay. It was very, very important, and for all of you, this is very important as you're implementing your own initiatives, that you make it clear to your team that ambulation is not the goal for everyone. Mobility is progressive, and every day may be different. For the most critically ill child on an oscillator, on multiple infusions, normalization of the sleep-wake pattern may be the most important thing we can do. Opening the shades, making sure they have quiet at night and hear voices during the day. And then over time, we can get to their baseline functional activities, which we know in the PICU is very different for each and every child. We had a shared mental model called the PICU Up levels, which gave us all the same framework to work with regards to critical illness and what that meant for the activities. And these are all in the PCCM paper in 2016. Sleep is a major priority because if you don't sleep well at night, you're not going to mobilize during the day. So this is key for our level 1, our sickest patients. And over time, you can see everyone got an OT or PT consult by day 3. Everyone was getting screened for delirium Q12. And then over time, activities progressed as patients become less critically ill. Sedation was one of our major challenges, and I bet it is for many of you. It was clear that we were approaching sedation often from our comfort levels and not necessarily for our patients. So we started to standardize our approach to administering sedation and making sure the indications were clear. And this was one effort that we made for PRNs, which often are a major culprit in escalating doses for children, especially when many PRNs are given. We had an online module for all of our PICU staff that focused on progressive mobility so that everyone, again, had the shared mental model of what PICU Up means. So what were our results? This was our first QI single center study. We found that 82% of patients had a PT session before they got discharged from the PICU, and that the median number of mobilization events doubled from 3 to 6. We had 0% adverse events, and that was very important to demonstrate that it was safe. And ET tube ambulation increased from 0 to 10%. And before we knew it, more and more studies started coming out looking at early mobility in pediatric ICUs. So in this talk, we by no means are going to be comprehensively presenting all of the different initiatives, but know that there are many studies out there in many different populations, including this one in the Onco-Critical Care Unit at St. Jude. 3 years later, how are we doing? Well, we asked our staff, what does PICU up mean, and how has it impacted our care, and what are your perceptions of it this far out? And what we found was overall there was a lot of positive perceptions of PICU up with regards to patient and family satisfaction, improved morale in the ICU, and communication. So what did this mean 3 years later? Well, we decided to ask our staff, what does PICU up mean to you? And we found that the things that made PICU up successful are having a greater focus on sleep hygiene, setting sedation goals, sharing successes and evidence, generating staff buy-in, and starting small. And we'll show you some examples of that. We had our staff tell us that it improved morale in the PICU, which we originally thought it would actually increase burden, but in fact it improved morale seeing kids mobilizing and sustaining the zest for living, which is a requirement for survival. Inconsistency with plans was a major barrier and challenge, and heterogeneity in patient developmental levels, but we had some things that we could do to continue to improve. And one of our major projects now is learning about simulation of mobility and implementing simulation for our nurses, who are the cornerstone of mobility, as I'll show you shortly. So we created a culture of mobility. We had success. We were starting to see more kids up and moving, awake and alert during the day with normal day-night cycles. So we mentioned Park PICU and some of the key findings here, including that parents being present at the bedside plays a major role in promoting mobility and having mobility protocols, which makes sense. And again, it's the invasive devices that often have the biggest impact in terms of being barriers. And most importantly, early mobility was safe. Only 4% of the 4,700 mobility events that we collected resulted in any change in mostly transient changes in vital signs. Another very important point here is that 62% of all the patients in Park PICU were under the age of 3. So we are taking care of children when they are not just in need of rehabilitation, but in need of habilitation. They are actively developing in front of our eyes. And so mobility is a key component of that. Nurses and families are the cornerstone of PICU mobility. The vast majority of these activities are conducted by families, and we have to remember that and give them the resources that they need in order to conduct these activities safely. And to that point, Jessica LaRosa, one of our PICU fellows and soon to be faculty at Johns Hopkins in our pediatric ICU, showed that among all of those activity events that were documented in Park PICU, the only clinical factor associated with the safety event was a delirium screen that was either positive or not done. Positive delirium screen or not done. So again, the ABCDF bundle, it all goes together. Activities on the study day, 4,700, only 4%, as I mentioned, had any potential safety event, and there were 7 displaced feeding tubes, no arrests, and no falls. So what's next? You might say, okay, well, early mobility is safe, that's great. It seems to be a good thing, but what about the outcomes? Well, we're starting to study that. So we have a stepped wedge trial that is currently ongoing. This is an NIH R01. You can learn more from clinicaltrials.gov if you just Google PICU up. These are the 10 sites that are involved in the study. Many of these faces will be very familiar to you, including John Birkenbosch, who's one of the key authors of the SCCM guidelines for the ABCDF bundle. These are the 10 sites that are participating in the PICU Up trial, and many of these faces will look very familiar to you, including one of our moderators for this session. So here we are. Are we letting kids be kids? Are we helping them to sustain the zest for living, which is a requirement for survival? Well, I'll let you be the judge. This is our first case, another example of starting low and going slow. A 2-year-old after a Fontan, post-op day 1, and normally this child would be sitting in a room probably immediately after her surgery. But we decided to pick you up, and Sydney wasn't having it. She threw a full-on tantrum in the middle of the hallway, and you can't blame her. Look at all of the invasive devices that she's tethered to: chest bulbs, a fresh sternotomy wound, an IJ line, an arterial line. And we found that a little creativity could overcome toddler spirit, because her parents said she came into the operating room in a little cozy coupe car. Can we find one of those? And this is what ensued.
You're doing so great.
It's a great exercise. Those legs.
Notice she's wearing her sandals.
Yeah.
A little piece of home can go a long way. And she went around our unit exactly 4 times, a 40-bed unit. This was the first child that we ambulated in our unit. As I mentioned, ambulation is not the goal for everyone, but for some patients it's possible. So she's a 9-year-old with alveolar rhabdomyosarcoma. We made a no benzo sign at our bedside given the risk of benzodiazepines and delirium. Gave her a low-dose morphine PCA to control her own pain. And she walked to the playroom, played with some Barbies, and we celebrated the success. This was the first time we had done this, and before we knew it, it became more common. So you might ask, what about our youngest patients? Well, as your culture changes, it's possible to do the most that we can for even the little babies. And it may not be possible for every baby, depending on their level of critical illness, but babies can be lucid. Toddlers can be lucid with an endotracheal tube if we address their pain and we use comfort measures. Often #therapeutic cuddles are the highest level of mobility that an infant or toddler can engage in. And even for the most critically ill infant like this little one, being in mom's arms is the most important thing that we can facilitate. We have patients on ECMO who are riding tricycles. You can see she has a prosthesis. She's had severe burns, and this ECMO circuit is riding behind her. And remember, safety first, always wear a helmet. So what should you take away from this talk? Well, the key is that it is never too early to begin to think about mobilizing and liberating the critically ill child. Liberation begins the moment a child enters the hospital and continues until the moment they leave. So post-intensive care syndrome is also an important consideration with post-hospital care syndrome. We have to value each other's expertise. I cannot tell you how much I've learned from my interprofessional colleagues, and we're at the SCCM Congress, and that's the essence of what SCCM does, is interprofessional collaboration, and that's what we need to do for early mobility. Consistency is key. Asking each and every day, what is this child's minimum activity goal? What can we make happen given the circumstances and the acuity of the unit? We can't hit the easy button anymore. We need to think about what's best for our patients and their routines. Analgesia first, and then consider sedation if needed. With any pharmacologic therapy, starting low and going slow is key, because children do become tolerant and dependent, and that can have a major negative impact on their ability to mobilize. And finally, we must push the envelope safely. We can always do more if we have the right resources and staff and expertise, but doing it safely is the most important thing. Celebrate all successes, big and small, because we have so much work to do. And this is a cake that we bought after our first 6 months of PICU Up, and we continue to find different ways of celebrating, whether it's a little swag, just to make sure that people know how appreciated they are for the hard work they do. And that is a key component of implementation. If you need more inspiration and ideas, I encourage you to check out our Twitter page at PICUP and Instagram at Hopkins PICUP. Thank you very much, and good luck implementing your own early mobility programs. Reach out anytime. Thank you.
Hello, my name is Stacy Williams, and I am a nurse practitioner at Vanderbilt Children's Hospital in the Pediatric Cardiac ICU and the Pediatric ICU. Today we're going to talk about care and comfort of the critically ill infant and child. We're going to look at ways to engage the family to help provide the best care for our patients. Here I've listed my financial disclosures. Learning objectives for today will include being able to determine the meaning of family-centered care, discover ways of transitioning from presence of family to true engagement and empowerment of family, and also discover how families can be utilized in each bundle element of the A through F ICU Liberation bundle. This quote comes from a mother whose child has been in the ICU multiple times. As a mother to a child in the ICU, you are unsure of how to comfort the child, what's allowed, what would cause more harm than good. You don't know what to ask for, how to advocate for your child, and collaborate with a medical team. You assume they know better than you because they have the degrees and experience. The lack of sleep and anxiety makes you feel crazy and stuck in the most helpless situation. True torture. This quote from this mom has resonated with me throughout the years because it shows you the true torture that this mom and most of our parents go through. They don't know how to care for their child, even though they're that child's parent. This is a way that we can hopefully start re-engaging the family and give them a little bit more empowerment of taking care of their child, and also having that connection between the parent and the child for better care for our patients. So what is family-centered care? It's the integration and collaboration of family members and the patient care team, especially in the care of dependent infants, children, or adults with complex or continuing health care needs. This is a very basic definition of family-centered care. This is a definition where each institution can start with, and then they can build upon what family-centered care is to them and also what it means for their families. So what are the critical components of family-centered care that an institution needs to think about when starting this process? Mutual, respectful partnership between the family, patient, and all components of the healthcare team are crucial. It's not just between the family, the bedside nurse, the nurse practitioner, or the attending physician for the day. It is every single team member that is involved in that patient's care. And the family is seen as being a part of that team. Family must be seen as having importance in the patient's life and care. This is said because, yes, family is important, but one thing we also need to take a step back and think about is who in this family is important to this patient. Just because birth mom may be at bedside does not necessarily mean that that is the most important person in the patient's life. So we need to break down and figure out who is the most important and have them involved, because they can be a key component of helping improve this patient's care. Family must be informed and allowed to have input and ask questions in the planning, delivery, and evaluation of care. This includes open communication. And finally, medical team members must acknowledge that emotional, social, and developmental support are integral components of healthcare. So how do we involve families outside of just having an open visitation policy? We know that there is a very distinct difference between families being present and actually being present in rounds. What institutions can do is go ahead and set expectations for the families, what they are going to do, what they can do, what they can be involved in. And this helps kind of set those boundaries and expectations and kind of starts that process of knowing that they can be involved in giving them that pass of, hey, we want you guys as a part of our care team. One of the first ways that it can be done is having families present in rounds. There's one study that looked at 161 PICUs from the US, Canada, Brazil, and Europe. 88% of the PICUs had one family member present for the majority of the time. 94% of the PICUs in the US and 100% of the PICUs in Canada invited families to participate in rounds, but only 40% in Europe and 33% in Brazil. Now, the best location to have these rounds is at the patient's bedside. That's so the families do not have to step away from their child. One thing to think about, though, is when a family member is present in rounds day 1 of ICU admission versus day 4 or their 4th ICU admission, unfortunately, it's going to be different. The first day, family members are in shock. They don't really know how to act. They don't know the questions to ask. And so one of the best things the care team can do is invite them to rounds, but then follow up in the early afternoon or after rounds or whenever someone from the care team has time, because this will allow the family to have time to think, get their questions that they may have that they may not have thought about in the moment. And it allows them to have a space to ask those questions, to maybe say, hey, I noticed this. What does it mean? And they can bring forward little pearls that we may be missing because they know their child so well, but we don't know them and their little nuances. Now, as time goes on, family may get a little more comfortable and be more engaged in rounds. Their comfort increases. This helps also increase their trust in the care team. It is important to have open communication and listen. Listen to the families. Listen to what they're saying, their questions, their, hey, I noticed this. Those little things can be so important. But also the family listening to the care team, and the care team speaking on a level that the families understand. The families can also be a second set of eyes when we're in the middle of rounds. They are going to be focused on their child, but they can be a second set of hands while the nurse is listening, or if the nurse has to step away. Now, COVID presented a very unique challenge for all of us in healthcare. We've all heard the stories from the adult side of not allowing family members to be present at bedside. In the pediatric world, at Vanderbilt, we were able to allow one caregiver at bedside for 24 hours. This presented the unique challenge of having not only to keep the family member up to date and engaged, but also the family members who could now not be present. The family members have lost this support system that they had in place before COVID. And so the care team really did take on a very unique role now as not only the caregiver to the patient, and in pediatrics, the care team has been kind of in a supportive role of family members, but it even increased and became more important during COVID when these family members had no one else at bedside but them. Now, there are still thoughts that having family present in rounds increases the time in rounds and decreases the time of teaching that learners have. Studies have shown that this is absolutely not true. One study actually showed that there was an actual decrease in preventable adverse effects by 38% when families were present in rounds. It did not change the amount of teaching, and it did not increase the length of rounds. Another way that we can involve families is having them present during procedures and CPR. Now, this seems scary to a lot of people. The thoughts are that they may get in the way. They may have increased anxiety watching a procedure or watching their loved one have CPR performed on them, and also increased anxiety for the medical team. Well, studies actually show that none of this is true. During CPR, families don't get in the way, but it actually increased their trust, and it increased their way that they see how the care team is doing everything they can for their family member. It decreases their anxiety for most of the part. Now, during procedures, the concern of the family getting in the way, data has shown that that is not true, and that if you're comfortable enough with the family members, they can be sterile and be present and actually help comfort the patient. Another concern is that it may increase the number of attempts of a procedure, and studies have shown that that is not true also. Now, a third way is having family conferences, and these are more for patients who have been here for a couple of days in your unit. It needs to be in a private room with open communication, and you can invite different services involved in the patient's care. This allows for questions to be asked, and not only just to the ICU team, but to the different services involved. And this is a time where emotional support can happen. The family can see everything that the child is being given care-wise, but also the steps that still need to be taken. Now to dive into family presence and how it can be utilized during each part of the A through F bundle. We'll start with A, assessment and management of pain and anxiety. Research shows that family presence actually has lower stress scores with parental presence during painful procedures for the patients. Not only does the patient have lower stress scores, the parents also have less anxiety when they're allowed to participate. Parents also have more trust and confidence in the care team when they're able to participate in the patient's care. Patients with parental presence during painful procedures are noted to have lower pain scores, which we all know that can lead to lower medication administration. And then also, I touched on this a little earlier, the little pearls of knowledge. The family members at bedside know the patient better than any single person on the medical team. They know their little quirks, their nuances, and they can bring those little things that we may not see and notice to our attention that will help this patient's care. Here I've combined elements B and C. Spontaneous awakening trials and breathing trials, and choice of analgesia and sedation. Family member presence can be crucial in actually allowing the patient to receive less sedation and analgesia. Some ways that this could happen is that they can be an extra set of hands. If a nurse needs to step away to another patient's room, the family member at bedside can help the patient by holding his hand, making sure the patient is not pulling at anything that shouldn't be pulled at. They also provide that familiarity. The patient knows their family member. They don't know the nurses. They don't know the doctors. And that can help decrease anxiety, so less sedation. The family members also know the child's favorite shows and can bring in favorite toys. And again, like I touched on earlier, the little pearls of knowledge that the family has about the little things with the patient that the medical team doesn't know and can be helpful in their care. For element D, delirium assessment, prevention, and management, familiarity is key. The patient knows their family member's voice, their face. They don't know the nurse's face, the doctor's voice, or even the room that they are in, the odd sounds that they hear around them. So having that family member there at bedside is key in this element. If your institution uses the PS-CAM or the PCAM for delirium monitoring and assessments, the family members can actually get involved here and do feature 2 of the assessment. They can have a toy, a stuffed animal, a blanket, whatever, and they can be involved in doing the delirium assessment with their child. They have an insight on sleep patterns. We all do not sleep the same. We all have very different things that we like that help us sleep, and the parents can provide insight into this. Also, important for delirium prevention is a schedule. Does a patient have a schedule at home that they are used to? And how can we help get them on this schedule to maybe help prevent delirium? For element E, early mobility and exercise, family members can be the motivator, the cheerleader, the extra set of hands, the let's get up and go. They know the things that can motivate them. Hey, let's take 2 steps to this. Or even they can be the motivator. In the PART PICU study, family engagement actually increased mobility for those less than 3 years in age and is associated with increased therapists providing mobility. Here are 2 pictures that show family presence. It's important to note that her mother was at bedside throughout the patient's entire hospitalization. But that is not who you see in the pictures here. This patient's grandmother was her biggest motivator. This is why it's important to have these interactions and these conversations with the families, because we were able to use this motivator kind of relationship that they had to help improve her care. Now, if a team member or mom or dad asked the patient to do anything and she didn't want to, she was 15, she had her own mind, and she would give us a look if she didn't want to do it. However, if grandmom asked her to do something, there were no questions asked. She did it. Whether that was sitting up, helping roll over, standing at bedside, or even going to a chair. So we honed in on knowing this to help motivate her to do things that were hard, but it pushed her and it improved her care. Now, the picture you see on the left is of her getting a respiratory treatment, and she had a lot of anxiety. But what is important to see is she's not getting medication because she's anxious in this picture. You see her grandmother with her arm around her, holding her hand, talking to her. And this helps decrease the amount of medication that she needed. So when all of these elements are put together, family-centered approaches lead to better health outcomes for our patients, wiser allocations of resources, as well as greater patient and family satisfaction.
Hello, my name is Ann Stormworken, and I am a pediatric critical care physician at Rainbow Babies and Children's Hospital. It is a pleasure to be part of this session, and I wish to thank the conference organizers and session moderators for the opportunity. In particular, thank you to Drs. Heidi Smith and John Birkenbosch for your unflagging enthusiasm, persistence, and guidance throughout this process. Like many of my colleagues, I was drawn to pediatric critical care because I wanted to help critically ill children get better. I learned, however, that some of our common interventions were harming rather than helping them. And that is really what the focus of these guidelines are all about: identifying and mitigating harm associated with care in the ICU setting and getting our patients back to their cutest little selves. You've already heard from expert colleagues today that harm associated with critical illness can take many forms. Patients may experience undertreated pain, protracted need for ventilatory support, under or over sedation, iatrogenic withdrawal syndrome, delirium, sleep disruption, as well as immobility. As the Early Liberation Bundle for Care of Critically Ill Children delineates, these are not isolated events, but interrelated variables causing iatrogenic harm not only during ICU and hospital stay, but most likely contributing to post-ICU syndrome in children. Survey data collected from 160 participating PICU institutions from 2017 through 2019 reveals significant variability regarding implementation of ABCDEF bundle components. Pain assessment and management, targeted sedation strategies, and family-centered care were incorporated in the majority of ICUs. However, spontaneous breathing trials, delirium screening and management, as well as early mobilization were less likely to be implemented. Incorporating all bundle elements may seem overwhelming to the bedside provider. However, when you consider the number of care touchpoints during one shift, optimizing bundle implementation is best served through EMR-embedded policy and procedures. Iatrogenic withdrawal syndrome is frequently encountered in ICU patients, and I would like to focus the remainder of my presentation on this topic. This working definition makes reference to the requirements of both drug exposure and the development of tolerance as prerequisites for withdrawal. However, it must be recognized that administration of analgesic and sedative agents with active metabolites, as well as patients with hepatic or renal insufficiency, will also influence the development of withdrawal. There are multiple signs and symptoms observed in patients developing withdrawal syndromes. They can be grouped according to the specific drug receptor interactions involved. Autonomic stimulation results in increased respiratory rate, heart rate, and blood pressure, as well as the development of diaphoresis and fever. Central nervous system hyperactivity manifests as behavioral changes such as agitation and inconsolability. Delirium is quite common, seizures are less commonly seen. Gastrointestinal dysfunction can be as mild as poor suck or as severe as persistent vomiting and profuse diarrhea. Unfortunately, current sedation practices involve co-administration of agents, making it difficult to definitively attribute symptoms to a unique agent. The signs and symptoms of opioid withdrawal have been well described by Finnegan in Opioid-Exposed Neonates and includes autonomic stimulation, CNS hyperactivity, and gastrointestinal dysfunction. This review by Kosher Lakota highlights the complex neurotransmitter and receptor interactions giving rise to these symptoms in opioid-related withdrawal. The complexity of these interactions at the molecular level, coupled with variable severity in a patient's exhibited signs and symptoms, underscore why it is imperative to use validated scoring tools for an accurate diagnosis. The prevalence of withdrawal is associated with opioid and benzodiazepine exposure in critically ill children has been reported to range widely from 5 to 87%. Accuracy is limited by a number of things. Common sedative practices in critically ill children involve co-administration of multiple agents, which influences withdrawal signs and symptoms observed. The preponderance of the literature includes single-center studies with small patient numbers and lacks information regarding weaning protocols as well as the use of alpha agonists. 2 multicenter studies, the RESTORE trial and a study by Amagoni et al. In 2017, reported a prevalence of withdrawal ranging from 35 to 68%. Accurate diagnosis relies on the use of screening tools validated in a heterogeneous population such as critically ill children. Ideally, these tools should also be used to monitor patients as you wean and ultimately discontinue the analgesic and sedative infusions. The frequency of assessment with screening tools will be determined by the presence or absence of withdrawal symptoms, as well as the need to monitor efficacy of therapeutic interventions. At baseline, they should be at least every 12 hours during weaning, with increased frequency of scoring as needed. 2 screening tools validated in critically ill children that are commonly used are the Withdrawal Assessment Tool, or WAT1, developed by Linda Frank et al., which is based on a 12-point scale. A cutoff value of 3 or greater is consistent with presence of withdrawal. The SOFIA Observational Withdrawal Symptoms Scale, or SOS, developed by Ista et al., is based on a 15-point scale, and a cutoff value here of 4 or greater is consistent with the presence of withdrawal symptoms. Risk factors for developing withdrawal associated with opioid and benzodiazepine exposure are related to the duration of exposure and total dose. Risk is elevated after 5 days of exposure. Cantor et al., as well as Ista and colleagues, reported these cumulative dose cutoffs in morphine and midazolam equivalents, suggesting that perhaps screening for withdrawal at lower dosing might be prudent. The use of 3 or more agents independently increased the withdrawal risk, but no one has identified specific agents within opioid or benzodiazepine classes that lower the risk of developing withdrawal. The RESTORE trial revealed non-pharmacologic factors increasing the risk of withdrawal. These included younger children less than 6 years of age, in particular those less than 6 months, the presence of pre-existing neurocognitive impairment, and acute critical illness associated with either a primary CNS disease or having CNS sequelae. Does administration of dexmedetomidine decrease withdrawal? A single study by Oshman showed a trend to decreased withdrawal in patients receiving dexmedetomidine, but failed to distinguish between the direct drug effect of alpha agonists versus opioid or benzodiazepine sparing effects. Alpha agonists are increasingly used as part of multimodal analgosedative regimens in critically ill children. Concomitant administration of opioids and benzodiazepines have precluded development of a specific alpha agonist withdrawal screening tool. The majority of sedation studies highlighting dexmedetomidine use are single-center studies. Pooled data from 5 of these studies indicate a prevalence of withdrawal ranging from 27 to 83%. The observed signs and symptoms of withdrawal are as expected due to rebound from alpha agonism and centrally mediated sedative effects. The majority of patients exhibit tachycardia, hypertension, and irritability. A cumulative dose of 107 micrograms per kilo was identified as a risk factor in a single study by Honeycourt. This correlates with a 1 microgram per kilo per hour infusion for 4 days. Other patient-specific risk factors remain unclear. Management of withdrawal acknowledges that signs and symptoms are attributable to receptor occupancy. Administering agents with similar receptor activity will mitigate withdrawal signs and symptoms. If signs of withdrawal occurs within the time frame of recently weaned or discontinued infusions, then administering an agent with identical receptor activity may treat those symptoms. Suggested options for replacement therapy have been selected from the cited references. It is important to recognize that no one protocol has been demonstrated to be equally efficacious in all ICU populations. However, the majority of protocols use an opioid or benzodiazepine with longer half-lives and available in both IV and enteral formulations. Selection of a specific alpha agonist usually means enteroclonidine because the patch formulation is not amenable to titration. Having reviewed the literature regarding the signs and symptoms, risk factors, and management strategies for withdrawal, I think it's clear that the holy grail is how to prevent withdrawal in the first place. So let's review what has been discussed earlier in regards to the PANDEM guidelines as well as this recent review by Ballot. Incorporating ABCDEF bundle elements in an effort to reduce analgosedative exposure is crucial to achieving this goal. Sedation protocols should be multimodal and have clearly identified analgesia and sedation targets. These goal-directed patient-specific algorithms developed for critically ill children may demonstrate these listed desired outcomes. And decreasing drug exposure could be achieved using either goal-targeted sedation protocols or daily sedation interruption. Let's consider goal-directed sedation protocols, wherein sedation targets are determined per patient needs and disease trajectory. The medical team determines the sedation target and drug titration is protocolized to meet those goals. The largest randomized controlled trial comparing this approach to conventional sedation, the RESTORE trial, failed to show differences in primary outcomes, specifically length of time spent on the ventilator, in the ICU in the hospital, as well as development of withdrawal. Upon secondary analyses of the initial study data, no harm or worse long-term outcomes were observed in the study group. Daily sedation interruption is a common practice in adult ICUs. However, because this involves cessation of all analgesic and sedative infusions, it is less frequently performed in critically ill children. However, multi-center randomized control trials failed to show decreases in outcome measures similar to the RESTORE trial. There was an increased need for prompt reintubation in the group with daily sedation interruption. Prevention of withdrawal can also be accomplished by avoiding rapid decreases in receptor occupancy. Protocolized slow weaning with frequent patient monitoring using withdrawal screening tools is such an example. Generally, there is a dosing decrement of no more than 20% of the total daily dose. It is also important to protocolize treatment for breakthrough withdrawal symptoms, as well as indications to either suspend weaning or resume previous higher dosing. Are there superior weaning strategies? One approach is to decrement infusions. However, this may prolong length of stay as well as increase the CLABSI risk if the patient is reliant on central vascular access. Alternatively, transitioning to intermittent administration using agents with longer half-lives and available in both IV and enteral formulations, in some studies showed a trend to a faster wean, with similar incidence of withdrawal. However, safe discharge on such a taper must be carefully considered for each patient. Let's consider the role of drug rotation in mitigating withdrawal development. Sanavia et al. Evaluated the impact of a drug rotation protocol on withdrawal. They used a multimodal analgesia and sedative protocol wherein opioids were rotated and sedative classes were also cycled amongst midazolam, propofol, and dexmedetomidine. Drug weaning was stratified based on duration of exposure. In patients with less than 5 days exposure, the drugs were rapidly weaned off over 2 days. Withdrawal symptoms were treated with methadone or clorazepate in this group. In patients with greater than 5 days exposure, there was a gradual wean. They received methadone or clorazepate prophylaxis, and breakthrough symptoms were managed with dexmedetomidine or clonidine. Based on compliance with the protocol, the groups were divided in two. The second group, comprised of 65% of the patients, failed to follow the protocol and was labeled inadequate rotation. The trends observed were a decrease in drug exposure, decreased withdrawal, and decreased PICU length of stay. But do the results of this study highlight patient subpopulations of those that were easier to sedate versus those that were not? In summary, it is recommended to incorporate as many elements of the early liberation bundle as possible into ICU protocols in order to mitigate harm associated with critical care. These include undertreated pain, protracted mechanical ventilation, under and over sedation, delirium, sleep disruption, immobility, and social isolation. I would like to highlight these specific recommendations for mitigating withdrawal. Perhaps most important is to identify your population at risk based on the analgesia and sedation protocols you use. Ensure accurate diagnosis and ongoing monitoring with validated tools. Use specific strategies to manage symptoms when they occur. And identify those preventative strategies that work best in your patient population. Thank you again for this opportunity. A shout out to the PANDEM guideline co-chairs and committee members, as well as my co-presenters. And a special thank you to all of you for taking care of the critically ill children all over the world.